Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, November 10th, 2024, and it is time for another IC Spoker meeting. A little tiny bit late today, only because the internet was not cooperating, but I got her done. You never know. Every day is an adventure when you're trying to do things on the internet. This is the Interstitial Cystitis Network. We work with men and women who struggle with pelvic pain, bladder pain, prostate pain. Our goal in doing these meetings is to educate, to inform, to give you hope, to give you comfort, to give you love, to give you encouragement. It's to teach you that you are not alone. You should not think that you're alone in this journey, because you're not. Because I've been on this journey, and many, many millions of other patients have been on this journey. But when this is new to you, it is difficult. It is difficult. It is scary. It is frustrating. You want to know why you're in pain. You want to know why. And it's hard. It takes time to find the answers. We're long past the days of believing that IC is an incurable bladder disease. We know that that's not the case. We now know that IC is a pelvic pain syndrome for which there are many potential causes. So the reason why these meetings are, I hope, valuable to you and helpful to you is that we might be able to open some new doors for you to explore. That is always going to be my goal. Now, tomorrow is Veterans Day. I have worked with many veterans with IC, active duty and retired, here on the IC network. Interstitial cystitis pelvic pain is actually a big deal. Pretty hard to serve your country when you're running to the bathroom every 15 minutes. Also served on the U.S. Army IC research panel for many, many years. And so to anybody out there who is a veteran, it doesn't matter if you're retired or active duty, if you're the wife of a veteran, if you're the daughter of a veteran, like I am the daughter of a veteran, I want you to know that I'm here for you. Doesn't matter if you're a man, doesn't matter if you're a woman. If you're struggling, I'm here for you. If there's something that you need that you might not be able to afford, call me. Because we always stop and serve our veterans. Now, the second thing I want to just talk about briefly before I get into this big presentation I'm going to do for you is that we find ourselves in unprecedented times right now, because half of the IC population is ecstatic and half of the IC population is depressed and scared. I've actually never quite been in this situation before, because I have both sides calling me. But the point is that we're not sides. In my neighborhood, as I was driving around, there were new signs going up on people's lawns, which was win or lose, we're in it together. And that ultimately is what I want to remind us all today, is that we are a support group. We are here to nurture, encourage, and support. When you call the IC network, I don't care what party you're in, it will never come up. We are bound together through our struggle with pelvic pain. We are here. We care. And so I just urge you now, as things are hopefully going to calm down, we all have to find some peace again. We all have to find some comfort again. And it's a journey. Support each other. Please, please support each other. Okay, now normally when I do these meetings, now you guys were simulcasting right now. So when I'm looking here, I'm looking at Facebook. When I'm looking over here, I'm looking at YouTube. In fact, let me move this a little bit over on YouTube here. If I move it all the way over, there you go. Now, I usually do a little 30-minute little educational intro, and then we take your questions. And I'm always happy to take questions. Hello, Gay. Nice to see you, Hunner. I hope you're having a good day. It's kind of a weird day here. Honestly, my stomach was really upset this morning, but it's kind of calmed down. I actually roasted a chicken last night, and it was terrible. That's really rare for me. Like, I overcooked it. No, my gosh. Anyway, life is a journey, right? Life is a journey. Okay. So I have been invited to give a presentation to a major medical association in Canada on IC. I'm doing it on Friday. And I want to give you guys a sneak peek about the presentation. And I want you to give me some feedback if you believe that I'm missing something, if you believe it's not quite done, but it's almost done. Like it's 85% done. So hold on a sec. Let me cue this up here for a moment. And so here's the thing. People on Facebook, you're gonna see the PowerPoint presentation. People on YouTube, you're not, but you're gonna see it later because I'm gonna post it later. So just bear with me here for a moment. Let me go ahead and set this up. And you guys, this is gonna be kind of like my rehearsal / run through. Because what we're doing here now is we're educating doctors about the many potential causes of IC. We're trying to get them away from saying you have an incurable bladder disease, here's some bladder meds, and sending people on their way. And in fact, I will tell you, another fascinating study just came out that talked very specifically about the types of meds that will work for certain people. And what this study found is that patients who have systemic pain, widespread pain, you're in that IC phenotype number 5, central sensitization. Those are the patients who respond to antidepressants and stuff, nerve calming meds. Patients, in contrast, who are bladder centric, who have, for example, estrogen atrophy, hi, Ann, those are the patients who are going to respond to something like a bladder installation. And I now think about the mind-blowingness of this, because for the last 25 years, every IC patient's been told they have an incurable bladder disease. Every IC patient's been put on bladder treatments and antidepressants. And they've been given the diet and maybe antihistamines, etc. Well, we know that a one treatment fits all approach doesn't work. It doesn't work for the vast majority of patients. And the question is why? Because, of course, we're very different. So you think about all those patients who took Elmeron for decades and it never helped them. Why? Because they probably had systemic symptoms like I do. And you think of all those patients who endured just massive side effects from amitriptyline, who, for example, might have had chemocystitis or estrogen atrophy. And here they gain 20 pounds, 30 pounds, end up with heart issues, all that sort of stuff from medications, when in fact, that medication would have had really no chance to fix the underlying problem. And so ultimately, hi, Denise, this is about identifying the underlying problem and fixing the underlying problem. Okay, so hold on a sec here. So for you guys on Facebook, I need to cue this up. Okay, so there it's that. So let me go here. And I'm going to give you my desktop. Now you get to see my messy workspace. Okay, let me minimize that up. There's the presentation. No, I don't need to try it. I need play from the start. Okay. Okay. I put a lot of time in this. So again, the goal here for you guys to see this presentation or hear this presentation is to tell me if you think I missed it or not. And actually, hold on one sec. Let me just make sure Facebook is seeing the right thing. Okay. All right. So who am I? I've been an IC support group leader for 31 years. I built the first website on IC in 1994, and it's been rated the top website in 2 peer-reviewed studies by Harvard and the University of London over in England. I've been a IC research panelist for many years. I serve on the AUA guidelines for the development of male pelvic pain. I'm a pelvic pain guest lecturer for the International Continence Society. I've written the book IC 101. It's not just a bladder disease, and of course our videos, etc. This presentation today is about phenotyping in the diagnosis and treatment of interstitial cystitis bladder pain syndrome. So what are our objectives? We want to review the history of phenotyping proposals and their recommended treatments, and this includes the systems proposed by Dan Shosky's, Chris Payne, Curtis Nickel, the Canadian Urology Association, and the AUA. We want to review the practical application of phenotyping in your clinic, and we want to share the value of phenotyping in patient education. So consider this: 6 patients. Each one has been diagnosed with interstitial cystitis or bladder pain syndrome. Our first is a 74-year-old female. She's got severe pelvic pain. She's got frequency urgency for the past 20 years. Her symptoms have worsened over time with poor quality of life. She has severe depression and anxiety. Cystoscopy finds Hunner's lesions. She has treatment for those lesions, fulguration, steroid injections, but the lesions continue to recur. She's been on Elmeron for 20 years with little effect. She's currently struggling with pigmentary maculopathy, and she's been on antidepressants for 10 years, and she's very diet sensitive. Now compare and contrast her to a 38-year-old male, also diagnosed with IC. He's a U.S. Army paratrooper. He has moderate pain, exacerbated when sitting. He has pain at the tip of his penis. He must strain to urinate. He has to self-catheterize on occasion. He has a normal prostate. The standard bladder therapies are ineffective, but he's not diet sensitive. Okay, now consider a 13-year-old girl. She has sudden onset frequency urgency. She can't sit through class without asking to use the restroom. Her urine cultures are negative, her antibiotics are ineffective, urethral dilations are ineffective, and she's very diet sensitive. Okay, let's compare and contrast her to a 21-year-old young male. Sudden onset of frequency urgency and pelvic pain at the age of 18. He has severe pain on bladder fill. Prostate is normal, dropped out of college, bedbound, very diet sensitive. And we have a 30-year-old female. Her frequency urgency began in her teenage years. She has persistent pelvic pain. She has early onset endometriosis with multiple excision surgeries. She has IBS, migraines, TMJ. She has severe anxiety and catastrophic thinking. She works as an attorney, or tries to, but she's very diet sensitive. And last but not least, we have a 56-year-old female. Her symptoms began at the age of 54. She has moderate nocturia, means she gets up at night. Her pain is described at the urethra and the vaginal introitus. She has pain with sex. She has pain on bladder fill. She can no longer enjoy a cup of coffee without discomfort. She's diet sensitive. So each of these patients had negative urine cultures. Each was provided antibiotics with no effect. Each was diagnosed with interstitial cystitis or bladder pain syndrome. Each were told they had an incurable bladder disease resulting in severe emotional distress and worry. Yet each experienced a poor response to conventional IC treatment, and they continue to suffer from flares. Why? Here's what we know in 2024. The IC patient population is remarkably diverse, including age, of onset, culture, profession, and history. We know that a one-treatment-fits-all approach, such as Elmeron, does not work for the majority of patients. We know that the U.S. National Institutes of Health has invested more than $100 million in IC treatment research, with only one study found to be significantly successful: pelvic floor physical therapy. So if physical therapy is successful when other bladder therapies are not, is this really a bladder disease? So let's take a look at a quick history and how perceptions of IC have changed over time. Early history, 1836. Dr. Parrish described the symptoms of IC as tic douloureux of the bladder. He wrote, "I have known great suffering in the urinary organs from this form of disease." His assumption was that it was a neuralgia of some type. In the 1850s, Physics and Byrne described patients with mysterious bladder pain in which no bladder stones were found. Because back then, they usually assumed the bladder pain was from bladder stones. And for those of you who've had bladder stones, you know that they're terribly painful. And in 1850, Gross describes inflammation of the bladder wall. He wrote, "The chronic form of the malady entails a vast amount of suffering, which, continuing for months or perhaps years, finally saps the foundation of life." So we've gone from nerves to inflammation just in 15 years. In 1915, Dr. Guy Hunner identified ulcers on the bladders of some but not all patients. These are now named after him, known as Hunner's lesions. It's about 5 to 10% of the patient population. In the 1940s, Hand described small, discrete submucosal hemorrhages and dot-like bleeding points that he believed represented the true nature of IC. But these are no longer considered a significant finding in the 2022 AUA guidelines, as they are not unique just to IC. And clearly, at this point in time, there were two distinct groups: patients with Hunner's lesions, patients without Hunner's lesions. And there were many patients who had normal bladders. Whoops. So in 1987, the US National Institutes of Health created their first guidelines for IC research, which a diagnosis was confirmed by the presence of Hunner's lesions or glomulations. These guidelines were quickly adapted by urologists. However, the NIDDK IC database found that 60% of patients did not have Hunner's lesions or glomulations. Let me say that again. 60% of patients did not have Hunner's lesions or glomulation. And again, if this is the case, is IC a bladder disease? In 2001, Dr. Jerome Weiss was one of the first urologists to expand his practice to include the assessment of the treatment of pelvic floor muscles. He published his first study on the effectiveness of physical therapy, showing remarkable success. 45 women, 7 men with IC or frequency urgency syndrome had manual physical therapy for 8 to 12 weeks. 83% had a moderate or marked improvement, and their resting pelvic floor muscle tension decreased from 9.73 to 3.61. Yet, this was essentially ignored by mainstream urologists for many years. In 2003, Rhonda Cotterinos and Mary Pat Fitzgerald published one of the first protocols to rehabilitate hypertonic pelvic floor muscles found in bladder and pelvic pain patients. They too were scoffed at an NIDDK IC meeting. Many urologists walked out of their presentation, which continued to be ignored by most clinicians and studies until 2009, 6 years later. In 2008, the European Society for the Study of IC, now known as the International Society for the Study of Bladder Pain Syndrome, released their consensus statement on IC as a bladder disease. So they were still defining IC as a disease. And to be diagnosed in Europe, you had to have a hydrodistension and biopsy of your bladder. And based upon what they found, you fell into 12 potential groups. This system is absolutely not viable throughout the rest of the world because most countries won't pay for hydrodistension, much less biopsy. In 2009, the Japanese and the East Asian guidelines for IC were released, and they termed it as hypersensitive bladder syndrome. They suggested that bladder hypersensitivity is associated with urinary frequency and bladder pain. They were onto something. They were the first to discuss in depth the concept of neurosensitivity in the IC patient population. And then we had a big breakthrough in 2009. We had our first pelvic floor physical therapy study. It was a multi-center study from the National Institutes of Health that found that pelvic floor physical therapy reduced IC symptoms 57% versus 21% of placebo. This was, and no other treatment had come even remotely close to that, bladder therapies, etc. So this was a critical turning point. This was a validated study proving that physical therapy was in fact more successful than oral meds. So if IC was a bladder therapy, why would muscle therapy help? Maybe it's not just a bladder disease. So in 2009, we have our first formal phenotyping system proposed, where we're trying to identify groups of patients. This was done by Dr. Dan Shoskes and Curtis Nickel of Canada. So they urged doctors to evaluate patients based upon 6 domains. What are their urinary symptoms? How are they functioning from a psychosocial standpoint? Otherwise, the depression, catastrophizing, which is actually a very important symptom. What do their bladders look like? Is there any sign of infection? What's the state of their nervous system? And do they have pelvic floor muscle tenderness? And then based upon these scores, patients were then given a customized treatment protocol. And so U-Point is basically how patients in Canada are now diagnosed and treated. Now, when this happened, what did the patients think of all this? Well, number one, we were ecstatic to see their whole body assessed rather than just the bladder, because we had already known, talking amongst ourselves, that we had widespread sensitivity. Why do so many patients have a very sensitive skin or a wicked sense of smell, which we now recognize as a sign of central sensitization? So this was, hi Donna, this was the first system that truly emphasized the development of an individualized treatment plan. Now, in 2011, the American Urology Association guidelines were first released for IC, which reflected some of these changes. Though they referred to IC as an incurable bladder disease, they added a pelvic floor muscle assessment and referral to physical therapy to their guidelines. And this expanded care from traditional therapies to include manual therapies. And please note that the 2022 guidelines report no bladder disease is found in the great majority of cases. They focus instead on neuromuscular origins. Yet sadly, I suspect that the majority of practicing urologists in the USA have reviewed these guidelines, have not reviewed these guidelines, which were updated in 2014, 2015, and 2022. So now we come to what has been a critical change in the diagnosis and treatment of IC. And that happened in 2015 when Dr. Christopher Payne, who ran the IC research program at Stanford University, proposed 5 distinct groups of patients, each with their own treatment. Whoops. So what was his rationale? That a diagnosis of interstitial cystitis doesn't give the patient or provider a clear treatment pathway. And that's very true. After you're diagnosed with IC, do you really know what to do? And the answer, of course, is no. And he says, well, not only do you not know what to do, really, honestly, your doctor probably doesn't know what to do either. And he said, as a model, he asked us to look at the far more in-depth diagnoses provided in cancer, arguing that they have a very clear treatment plan. With phenotyping, IC patients can receive a more intuitive and effective treatment plan because it is a more in-depth diagnostic workup. And he proposes 5 core phenotypes, but suggests there are probably more. In his group, subtype number 1 are Hunner's lesions. These are the people who have wounds on their bladder. They have profound inflammation on biopsy. They have extreme symptoms and extreme diet sensitivity. Multiple studies have now found virus in the urine of these patients, usually the polyoma BK virus or the Epstein-Barr virus. Antiviral therapies are now being studied as a new treatment for Hunner's lesions. And yet we did have a case study which found posterior fornix syndrome related to lesion development too. So what's our therapeutic priority for patients with Hunner's lesions? Lesion-specific therapy. We need to fulgurate them, laser them, inject them with a steroid, maybe some hyperbaric oxygen therapy, because these patients can and will suffer for years if they're not provided direct treatment of the lesion. These patients do not respond to Elmeron. These patients do not respond to an antidepressant. Might slightly improve their symptoms, but as long as you have an open wound on your bladder, you're screwed. We've got to help that wound heal. Hunner's lesion patients need strong pain care. Pain must be monitored, and multimodal care is essential. And for these patients, diet modification is everything, because as long as you have an open wound in your bladder, it's going to react to food. Now let's go to his second phenotype. His second phenotype is bladder wall driven. In this, there are three or more variants. We've got chemical injury to the bladder. So these are the patients whose symptoms are caused by chemotherapy or ketamine or a poor diet. We've got genitourinary syndrome of menopause as a really big patient group in this patient population. We have chronic infection, bacterial, fungal, or viral, Lyme disease, maybe even black mold in their home. That's a small group. I know that there are some people out there who want to say that this is every IC patient. That's not the case, but there's a small group of patients who are going to have chronic infection. And we've got some autoimmune cystitis going on, perhaps for patients who have lupus or Sjogren's syndrome. What are our therapies for this group? We want to remove the irritants to the bladder. We want to support, protect, and soothe the bladder wall using topical estrogen, maybe chondroitin-based supplements like Bladder Builder, Sister Protect, or Aloe for a soothing effect. Oral medications like PEA and amitriptyline and hydroxyzine, which can reduce mast cell activity, can be viable treatment options. But we must be cautious of Pitocin, Elmeron, pigmentary maculopathy, inflammatory bowel disease. Now we know that this once gold standard treatment for IC can have very, very profound and damaging effects to the retinas. And of course, for this group, we can do bladder installations like heparin and lidocaine, aka rescue installations. In the pain system, our third phenotype is pelvic floor driven. So these are the patients whose symptoms are the result of a previous pelvic trauma, like a car accident or falling off of a ladder or downstairs. They often have a history of childhood or extreme athletics or dance. Some have experienced injuries while delivering children. Some have been sexually abused. For these patients, symptoms can begin at a very, very young age. And the importance here, long-term muscle tension can result in pelvic ischemia. So what are our therapeutic priorities for this group? We want to restore good blood flow. We want to restore good muscle tone. A healthy muscle feels like a raw chicken breast. A tight muscle feels like a cooked chicken breast. A badly damaged muscle feels like beef jerky. We must address trigger points with manual therapy or trigger point injections. We must address skeletal abnormalities if muscles are returning to chronic tension after physical therapy, such as is there a problem with the SI joint, the tailbone, the hip, the knees, the feet? And most importantly, patients can be taught to recognize tension early and treat it with stretching and internal massage. Okay, BPS subtype 4, pudendal neuralgia. This is driven by nerve injury. These patients have positional symptoms. They're fine when they stand, but when they sit down, it hurts. They might experience pins and needles, numbness, PGAD, or fasciculations, which is a vibration in the pelvic floor. Pudendal neuralgia is often the result of tight muscles compressing nerves, such as sciatica. Risk factors include bike riding, horseback riding, and motorcycle riding, and or sitting for long periods of time. So what are our therapeutic priorities for this patient group? We're going to identify the compression. We're going to reduce the contracture and restore muscle tone with physical therapy. We're going to calm nerves topically and internally. We might use topical anesthetics like lidocaine, nerve blocks, or PEA or Neurontin. And certainly, most importantly, we must avoid bike riding and sitting for long periods of time and other triggers. Our last phenotype in the pain system is central sensitization. These are patients who have widespread pain. They got the IBS, the vulvodynia, the TMJ, the fibro, the migraines, etc. That would be me, or I used to. They have extreme sensory sensitivity. They're going to be sensitive to skin, have skin sensitivity, smell sensitivity, taste sensitivity, sound, and light. They're going to have food, chemical, or drug sensitivity. They're probably going to have anxiety disorder and catastrophic thinking. And in this group, some genetics might be at play. So what is this all about? This is a central nervous system dysfunction. Brain scans have found that patients with widespread pain are in constant fight or flight. Defined as a central nervous system maladaptation, this is not mental illness, but rather the result of a nervous system injury. 80% of the children who develop widespread pain as an adult have a history of physical trauma, and the other 20% have a history of abuse or bullying. In 2018, the NIH MAP Research Network, that's a multidisciplinary approach for the study of pelvic pain, that's the IC research team, found that adverse childhood event severity was elevated in 421 IC patients when compared to controls. These were associated with complex chronic pain, pain syndromes, and perceived well-being. The more severe the adverse childhood events, the less likelihood of improvement and worsening of pain symptoms. So what are our therapeutic priorities for this group? We have to tell and train our brain that we are safe. How? We do that with some mind-body medicine technique. We must address anxiety and catastrophizing, which reinforces fight or flight and always intensifies pain. We must embrace positivity because pain that's accompanied by laughter is minimized by the brain. And we're now studying brain nerve stimulation. That would be Dr. Jason Cush at USC. But this is a really significant obstacle because this patient group, the widespread pain patient group, may be responsible for the great majority of clinical trial failures. Bladder therapies cannot address the underlying problem of central nervous system dysregulation. So should a CSS patient be included in a bladder therapy study? I believe that they should be excluded to avoid negating the study results. Oops. So what are the advantages of the pain proposal? It's ideal for use in the clinic. It's simple, it's easy to explain. It provides an intuitive treatment plan for each patient. It validates the use of specific therapies such as topical estrogen for estrogen atrophy or antidepressants to calm the central nervous system. It helps patients understand the value of different medications and why we use them together. And it puts self-care and mind-body medicine into context without offending patients by suggesting that their symptoms are all in their head. The symptoms are all in their nervous system. Now we go to the king of phenotyping, which is Dr. Curtis Nickel. 2 years ago, he said, hey, there are 9 groups. His rationale is based upon the work that he has developed working with thousands of patients in his career up in Canada. He's passing on his wisdom. He wrote, I've been asked by urologists many times over decades how to treat a specific patient with IC and found that I gave a different answer based upon each patient's clinical picture. He also said a stepwise one treatment fits all approach is doomed for failure in the majority of patients suffering from IC, which is certainly what we know. So he believes that there are 9 distinct groups. And the cool thing about his system is that he has provided recipes for treating each group. Group number 1 is inflammatory. These are patients who have Hunner's lesions. And like we said before, they would be cauterized multiple times, and he switches to steroid injections if necessary. He believes that for early Hunner's lesions, a classic rescue containing lidocaine might be helpful. But for patients who don't respond to any of these treatments, cyclosporin has been successful. His second group is new. Nobody's talked about this. He believes that there are patients who have a history of recurring UTI that may be experiencing a bladder hypersensitivity syndrome secondary to the infection. He believes that antibiotics should be put directly into the bladder as compared to taken orally. And he's a big supporter of the new UTI vaccines. He also believes in the value of next generation DNA urine testing to find rare or more challenging infection. His third group is neurogenic hypersensitivity, widespread pain, or chronic overlapping pain condition. For these patients, he suggests the use of low-dose antidepressants. That makes total sense. He suggests bladder installations that might support the gag layer. I don't know about that. He suggests using a lidocaine in installations to calm nerves down. And that makes total sense. His next group also is not defined by anybody else, multiple allergies. So these are patients who struggle with bladder symptoms in addition to respiratory, environmental, or dietary allergies. These are easily identifiable during cystoscopy by gently poking the bladder with a cystoscope to look for a mucosal wheal, a little red bump. If poking the bladder causes a little red bump, we know we're dealing with allergenic symptoms. So these are the patients who are going to do the best with an antihistamine and a strict diet. His fifth group is pelvic floor pain. He wants doctors to look for pelvic floor tension and trigger points. And he wants doctors to focus on treatments that target muscle health, like localized heat, stretching, relaxation, physical therapy, and skeletal muscle relaxants. He believes in using nerve blocks for localized pain and Botox therapy, though he personally did not use Botox in his clinic. His sixth group is primary storage symptom syndrome. So these patients are running to the restroom due to bladder pain pain on bladder fill. And he recommends using antimuscarinic medications of the pain once the pain is controlled. And a good example of that is mirabegron. He suggests bladder training to increase capacity, Botox as a last resort, and he does not believe that neuromodulation is helpful. Number 7, urethral pain syndrome. Again, no one else has talked about this. This is a new phenotype where pain in the urethra, sometimes it's the only symptom. He says the pain can be constant, episodic, or associated with urination. He believes that these are some of the most difficult patients to treat, and he suggests topical lidocaine to numb the urethra, vaginal estrogen, localized or oral amitriptyline, phenazopyrene, Valium, and or a periurethral block. Sexual pain. Pain with intimacy must be addressed in patients who are sexually active. The location of the pain must first be assessed. Is it coming from the vagina, vulva, pelvic floor, bladder? We want to treat it with pelvic floor physical therapy, topical lidocaine, topical estrogen to improve skin health and integrity. And his last group is IC flares, because flares require additional care and treatment. Flares can be triggered by diet, menstruation, stress, other infections, inflammation, or intimacy. They can last from hours to days, and he suggests the standard flare treatments that we talk about. So what are the advantages to the nickel proposal? Well, it takes a deeper dive into other potential causes of pelvic pain. He reminds us all that flares require treatment, and his recipes for treatment are thorough and customized for each phenotype. Okay, that's how far I've gotten. So now what we do is we go back to, there's more I'm going to add, probably 10 more slides, and we're going to end it with going back to the patients that I highlighted at the beginning. And we're going to phenotype the patients that I highlighted from the beginning. So we have a 74-year-old female, severe pelvic pain, frequency, urgency. Her symptoms have gotten worse over time. She has severe depression and anxiety. She has Hunner's lesions. The challenge here is fulguration and steroid injections are not particularly helping. The lesions are continuing to recur. So we want to get her checked to see if we have an active viral infection. Hunner's lesions, virus. I was working with a patient like 10 days ago. This is her. And she already knew she had an active Epstein-Barr infection. So phenotyping is going to identify viral-driven symptoms combined with estrogen atrophy because of her age. And in all likelihood, her pelvic floor is a little tight too from all the pain. The fundamental problem, in all likelihood, is that viral infection. So let's go to our 38-year-old male paratrooper. He has pelvic pain exacerbated when sitting, pain at the tip of his penis. Bladder therapies don't work. He is not diet sensitive, which tells us we have a healthy bladder wall. His symptoms began because he was a paratrooper. He had many, many falls on his tailbone. So this is a pelvic floor pudendal neuralgia patient. So let's go to the 13-year-old female. Her symptoms started suddenly. She can't sit through class without asking to use the restroom. Urine culture is negative, antibiotics ineffective, urethral dilation is ineffective, and she's diet sensitive. This is me. This is me. I have a healthy bladder wall. There's nothing wrong with my bladder wall. My symptoms started after I fell and broke my tailbone. My muscles were very tight. And that began this cascade of issues. Let's go to the 21-year-old who developed sudden onset frequency urgency. He's got severe pain on bladder fill, prostate normal, dropped out of college, bedbound, extremely diet sensitive. There's actually two guys that I'm thinking of for this one. The first one was a football player. And I thought, okay, all the trauma from playing football. But when I asked him what he believed caused it, he said he knew exactly when it happened. He fell off a ski lift skiing. And then the other guy that I'm thinking of was a kid in New York, same exact thing. He was using ketamine and he had ketamine cystitis. They were both bedbound. They were both unable to function or go to school. Okay, how about the 30-year-old female? Her symptoms began in her teenage years. She's had persistent pelvic pain her entire life. She has early onset endo. She's had multiple pelvic traumas, and now she has a widespread pain. So this is an endometriosis patient, and how that endometriosis triggers neuroinflammation throughout the entire pelvis, and then eventually throughout the body. That's why we see the anxiety disorder, and that's why we see all of the other pain conditions. So let's go to the 56-year-old female. Her symptoms began at the age of 54. She has moderate nighttime urination. Her pain is at the entrance to her urethra and vagina. She has pain with sex. She has pain on bladder fill, but she can't drink coffee. She's an estrogen atrophy patient. She's in the pain system, bladder wall, genitourinary syndrome of menopause. She does not have a bladder disease. There's no bladder disease here. Her symptoms are being caused because her muscles are so tight. All right, so anyway, that's where I am with my presentation. Hold on a sec. Hold on a sec. Now I've got to. Yes, it is recorded. Okay, so hold on a sec. Did you guys not even see the slide? No, you should have seen the slide. All right, we're going to go back to my face. Okay. Whew. This is basically a 45-minute presentation. Anne says, can phenotypes overlap? Absolutely. Is this recorded? Yes. And I will be doing a master recording of it that will be one of our videos for sure. All right, guys, I need to go use the bathroom. Give me a minute. I'll be back. Bathroom break. All right, I'm back. Sorry, whatever I made for dinner last night has completely messed up my guts. My IBS is talking to me. It's like my fourth or fifth trip to the bathroom today. So we'll see how long I last. I haven't had a major IBS attack in years, but this is not typical IBS. This is directly from me eating something last night. Again, I made roast chicken and I did the thermometer in there and it was well cooked, but my body does not like it. All right. So I would love your feedback on that presentation. Obviously, it's for doctors. Kayleen says she has so much pelvic pain today. I'm sorry, Kayleen. Anne says, can phenotypes overlap? The answer is yes, they can. Hi, Loretta. Kayleen says, I understand I had a catheter yesterday. Hold on. Your urethra is buzzing all the way to my pubic bone. I did decide to have a pop-up appointment with my urologist. He said he's going to teach me how to straight cath, but I think it should only be just in case. You guys, at least on my screen, the stream to YouTube is good. The stream to Facebook right now has gotten really fuzzy. Facebook, you are on AT&T. YouTube, you are on Comcast. So right now, Comcast is doing well. AT&T right now appears to be sucking a little bit. Kelly, the buzzing that you're feeling implies that we have got very, very irritated nerves. An irritated nerve can vibrate. It can what we call fasciculate. It's kind of like an eye twitch. It's where a nerve is making the muscle around it twitch a little bit. I have a lot of buzzing around my left sit bone, so I can totally relate to that. Totally relate to that. So how are you guys doing? I mean, listen, I know it's been a really hard week. And I think most people are staying off of the internet completely because it's not a healthy place to be right now. So I'm not surprised that we don't quite have as many people as we normally have. That's perfectly fine with me. But how are you guys doing? We're not talking politics. We're talking specifically, how is your body right now? Are you okay? My body is in the throes of recovering from surgery. So my body is not normal. I am sorry to say my body is messed up. I wish I felt better, but I don't. I mean, I had 2 good days last week where I was pretty good, but most of the time I'm just like on a scale of 1 to 10, I'm like a 6. Denise says, no pain for me for over a month. Yeah, baby, that's what we love. Excellent. Why do you think that? Is it because you're following the diet? Is it because you're doing pelvic floor? What do you think has gotten you to the point where you're not in so much pain anymore? Kayleen says she is stressed. Girl, we all are stressed. What a baffling world environment we're in right now. I just feel like the stress level is just, I've never been in so much stress in my life than I have this year. And last year was pretty damn bad. But, between breast cancer and so like, what do you do? Because when I was younger, when we didn't have the internet, we read the newspaper in the morning and we watched the news at night. And then for the rest of the day, we were out being kids. We were out walking. We were out going to school. We were going to work, whatever. And it was happy. It was happy. And now today, it's like the entire internet has been weaponized against our sanity and our stress because, like, everything we see, we're bombarded. If you're carrying your phone, you're being bombarded. And that doesn't allow us to find that place of peace and calm and comfort. And yet, the newspapers are so expensive now. I mean, it's like $600 for a year for my local paper. Cable TV is so expensive. I'm paying $175 a month for cable TV. And really, honestly, I watch like 2 channels. I am not interested in sitting in front of the TV for hours anymore. It's too much wasted time. And so, so then you go to your iPad, and then before you know it, or your phone, you're carrying it around all day. And you're being triggered. We're being triggered all the time. I don't want to be triggered anymore. Donna says she's got a lot going. Honey, I thought so. Girl, I thought so. Honey, I'm here for you. And if you need to talk, if you want a hug, I'm here. Because I know what it's like to go through some pretty difficult medical stuff. And I just want to give you comfort and friendship, hon. So call me when you can, okay? And if there's anything that I can do to help, Donna, please, please, please let me know. Valerie says she's absolutely miserable right now. Yeah. I think so. How do we get better? How do we calm this down? Number one, we have to take responsibility for our body's physical, mental, and emotional health. And that means I think for a lot of us, it's getting off of the internet as much as we can. It's getting outside, it's gardening, it's walking, it's making food, it's making Christmas cookies, going to Christmas fairs, it's going and watching a hockey game. It's just putting a bubble around our consciousness that all this fighting on the internet can't penetrate. I have this a little tiny bit of high blood pressure, and that came from caring for my elderly parents. And it's very, very mild, but I'm on meds for it. And I'm on losartan, and I'm on low pressure. And I always ask myself, do I feel calm? And I can rarely say yes. The only time I feel calm is when I paint. If I'm sitting at my little desk where I paint, that's when I rest. I don't feel calm playing Fortnite. It amps me up. I don't feel calm being online and reading stuff. It's just, it's like it digs away at your sanity in a way. So I don't know. I guess for me, I have to take charge of my mental and emotional and physical health. It's eating better, it's exercising, it's staying off of the internet. I'm being very clear about what I'm allowing into my brain. I'm not watching scary things, I'm watching happy things. I did a Harry Potter marathon last weekend. I'm 64 years old. I love Harry Potter. I want to go back and watch some of the old things that we watched when we were kids, like Mayberry, the Andy Griffith Show, and I Love Lucy, and those weren't traumatic, they were fun. All right, Denise says, you get some pressure sometimes. Denise says, because I stayed on a strict low-acid diet for 4 months and went to pelvic floor therapy, estrogen cream at night once a week. Perfect, girl. Perfect. And you also paint? Yeah, you just like get into the zone. You just get into the zone of I usually put a book on tape on, or I'll put on a documentary or something like that, but something. Oh, and then the other thing too is I'm really, like on YouTube now, there are a lot of music streams that are all like autumn, fall music, just like soft and gentle. There's videos where there's a cat in front of a fire and they're playing beautiful music, or, it's just like I want to fill my environment with. I don't want to live in a silent home. I want to live in a home where you can hear love, which is really hard when you live alone. That's really hard, but I'm working on it. Valerie says, you had your inner battery changed Wednesday and then drove 10 hours for a work trip. Girl, wait, what? You had your inner battery replaced, which was a surgical procedure. Then you drove for 10 hours with a fresh incision on your butt cheek, and nobody gave you pain meds. Man, this is something we have got to work on. We have got to work on this. Because somebody last week was saying, like, they were saying that one political party caused the opioid drug crisis, and I schooled them promptly. Hello, I chaired the California Pain Conference years ago. The opioid pain problem was caused by a drug company who saw a quick way to make a buck. They created a synthetic pain med, and they told the entire medical community around the world addiction was not possible. OxyContin. And so you had this devastating message that these synthetic, highly addictive pain medicines were not addictive. And so what happened is it became a gravy train for the pharmaceutical companies. It's like, oh man, let's jump on that. Let's jump on that. And then before you know it, all these companies were making synthetic opioids, and then they were shipping tens of thousands of pills to a little pharmacy in a town in West Virginia with 500 people getting like 300,000 pills. And of course, where did those pills go? They went onto the black market. They went into the drug community. And then we had doctors who jumped in on it, and they started setting up pain clinics, and where they were just handing them out right and left. And of course, that is the foundation for the opioid crisis. That was not a political party. That was greed. It was just pure and simple greed. And that company no longer ceases to exist. They're working very hard to hold the owners of that company liable. They're all billionaires because they knew it was addictive, but they continued to share the message they were not addictive. Same thing with the tobacco industry. They knew it was addictive, but they kept saying it wasn't addictive. And how many people have died from a lung cancer? So the backlash has been devastating for patients like Valerie, because there is a legitimate opioid problem. Legitimately, tens of thousands of people overdosed. The Center for Disease Control had to step in. They had to create guidelines to try to save lives, but their guidelines were terribly flawed. And they've now updated those guidelines twice, including very recently. The problem is is the first round of the guidelines basically cut every patient off. Even patients who've been using pain medicine responsibly at low doses for years, everybody got cut off. And of course, the flaw with that then is these patients then had to go, some of them went and bought heroin. You'd rather be on heroin than suffer from agonizing pain. And I think what appalls me now as a patient, and I think that this is something like we have to mobilize on next year. I need to reach out to some of the pain organizations again, is that this is becoming very common, Valerie. I was working with a patient 2 weeks ago. She had a hysterectomy, she had a rectocele repair, and she had a bladder lift, all in the same procedure. She assumed they would give her pain medicine when she left that day. She was given Tylenol. And let me tell you, that woman, severe PTSD from that. She will never trust another doctor again. She could not sleep for weeks because the pain was so severe. A rectocele repair is a devastatingly painful procedure. And I think what we have to do as patients is at your pre-op appointment, you've got to say, hey, how are you going to treat the pain? And if the doctor says, oh, we're not going to treat the pain, Tylenol, I would then just say, then I'm going to get a second opinion. When I had my hysterectomy, that was the first question I asked. So you're going to treat the pain? Yeah. He goes, okay, I'm not going to trust that your team at the hospital will do that. I want my prescription now. I want it filled and at home. So when I come home, it will be there. And luckily, my gynecologist, who knew me well and knew I was a pharmacologist, knew he could trust me. And that's what I did. And I never abused it. And even for the double mastectomy, I get my pre-op. It's like, okay, how are you going to treat the pain? Because I'm not doing this without pain care. And my surgeon was like, oh, no, well, I'm not doing it without pain care for you either. Of course, you're going to have pain care. And I had Norco for a week. Ironic that literally as I'm talking about that, my incisions just hurt. I could have used 2 weeks of pain meds or 10 days of pain meds. So I did get a little bit more. Valerie says here, I don't know what to do anymore. I'm 10 hours away from home for 2 weeks. Any suggestions for pain relief? My doctor told me to alternate Aleve and Tylenol. It's not touching my pain. Valerie, is there any chance do you have a fever? Because unfortunately, anytime you do surgery down there, there is a really significant risk of infection, a nosocomial infection from the procedure itself. There are hundreds of adverse events of this happening reported to the FDA. If you're paying, like when did you have this done? Oh, you had it done on Wednesday. And they told you could drive 10 hours after having that done? If they did, I hope you're going to chew them out, because putting a patient with a fresh incision in a car, a fresh incision on their butt in a car for 10 hours is cruel and unusual punishment. I think you could go to urgent care. I think they need to look at your incision. Let's see if it's inflamed. Let's see if there's any sign of infection that would help us understand the level of pain that you're in. I think it's appalling, honey. She said my husband drove, but yes, they were well aware. I think that I can still remember a patient who she had urethral cancer from HPV. And they removed her urethra, they removed her bladder, and they did a total hysterectomy. And they told her she should go back to work 2 weeks later. And she was sobbing in pain 2 weeks later. And she called me and like, does that make any sense? And I'm like, hell no. Are you kidding? It takes a year to recover from bladder removal. They've literally hollowed you out. And they think you can go back to work in 2 weeks? I call bullshit on that. No freaking way. You work with any patients who've had bladder removal, they're, minimum 2 months before they're gonna be able to function partially. But they're not gonna feel their normal self for at least a year. Amy says, "Happy Sunday. Still flaring from a hydrodistension 5 weeks now. I emailed you. I need the Epstein-Barr info." Okay. So you should not be flaring from your hydrodistension 5 weeks later unless you have a post-op infection. Any of that superficial damage done by the hydrodistension should have calmed down significantly and healed. So the fact that your pain is persisting implies a couple of things. Number one, is there any chance that we're dealing with a post-operative infection for you too, Amy? And number two, did they do what we call a high pressure hydrodistension, which stretches the bladder more, which injures the bladder more? And our national guidelines say that high pressure distension should not be done anymore. So I'm so sorry that you're flaring 5 weeks later, and you need the Epstein-Barr info. You know what? Hold on a sec. Let me just see if I can grab that for you right now. Let me see. It's in a bunch of different places. All right, here is my article on it, which has 8 journal references, all related to Epstein-Barr and urinary fungi. So go to that link, and then you'll find all the references right at the bottom to that. Ugh. Sorry, you guys. When I'm doing this, it's just my incisions are just so annoying. Amy said, "I have other questions I put in my email too. I hope my bladder will heal. I've had some good days." Amy, let me see if I can find that email. Hold on. I have been working on that big presentation also. Oh, here it is. Okay, honey, do you want me to kind of respond online, or do you want me to respond privately? You tell me. I mean, there's nothing here that is not what we've seen. And so I don't see anything here that would. And you're close, girl. Hey, you're up. You're in California. California girls rock. So my question to you is, can I answer some of these? I can try both. If Amy, would it be okay if I read your email aloud, or because it's just a classic, typical flare? Again, there's nothing in here that's not at all unusual. Okay, you said yes. Okay, well, so since we just did that whole okay, she said that's fine. So let's look at Amy's story, okay? So she's had bladder issues from the age of 3. And they were told back then. And Amy, how old are you now? How old are you now? Okay, so she's 42 now. So she's had bladder symptoms most of her life. In 2017, her symptoms began or got very, very severe after being with somebody who had returned from combat. Um, Amy, the exact same thing happened to me. My ex had just come back from the Middle East, and what happened to me is after we had sex, my, okay, my entire mouth was covered with canker sores, and that wasn't from oral sex; that was from kissing. I had at least 100 canker sores at one time on the roof of my mouth, which the infectious disease doctor said came from the Middle East, something that they were exposed to in the Middle East. So back in 2017, you had your urethral dilations, okay, which we don't do anymore. You had DMSO, hurt like hell, okay. Hydrodistensions with some steroid injections helped. Low dose naltrexone made your Hunner's lesions go away, but you had some side effects from the meds. And then you tried a biologic called Tezspire. I don't know anything about Tezspire. Yeah. Hey, listen, 100 canker sores at once they were on the roof of my mouth and they were under my tongue on both sides. It was a nightmare. It took probably 6 weeks to go away. It's so painful. And, he died. He died 2 years ago. And he was 5 years younger than me. And clearly he passed away from probably burn pit exposure. So Tezspire is used to treat asthma. Injected under the skin every 4 weeks. Is used in addition to other asthma treatments to help prevent severe asthma attacks. All right. You're now off of all meds, doing okay with other health. September 30th, you had a hydrodistension. And you have bladder spasms. It's probably a urodynamic. Well, hard to say. 200 ml. She had to hold your urethra for a second fill of 600 ml, and glomerations occurred. Kind of a pointless test now. After week 3, you felt better. You had a heparin installation 10 days ago. Felt great. Now you have spasming bladder and a burning urethra and a tight pelvic floor. Along with POTS, chronic migraine, myofascial pain syndrome, rapid gastric emptying, diverticulitis, dry eye, asthma, dysautonomia, high tone pelvic floor dysfunction, ulcerative IC. You're taking D-mannose. You tried lactoferrin, but it gave you cramping and diarrhea. You could start quercetin again. Okay. Girl, as Deanne says, you have been through hell. And I'm so sorry. I think that you are the perfect example of a multimodal approach to treatment. You can't just do one thing and expect this all to go away. So concept number 1 are the Hunner's lesions. Are the Hunner's lesions active right now? When they did the hydrodistension, did you have any Hunner's lesions? Number 2, because if you did they treat them? If you didn't, that's great. The second thing I want to know about is your pelvic floor. We know Okay, so they said your Hunner's lesion came back, right? And was it just one Hunner's lesion? Oh, Dean says, I meant you, Jill. You've been, hey man, we've all been through hell. We have okay, no Hunters. Okay. So Amy, that's spectacular. So let's celebrate that for the success that it is. You do not have Hunner's lesions. Praise God, hallelujah, those are gone. And the petechial hemorrhaging, inflammation in your bladder wall, okay. What could that be coming from? Well, that could be coming from, like you said, is there a chance that you've got a viral infection brewing in there since you have a history? Um, she says she believes she has atypical Hunters are observed as only slightly reddish spots, but with normal capillary structure. They can also show up as scarred areas and they rupture with massive bleeding during and after hydros. Well, I guess, did you have massive bleeding after the hydro? Did she see, Hunner's lesions are known to bleed. They call it a waterfall effect. It's like a blood waterfall. Hi, Renee. Renee says, getting on a little late. Yeah, we all were. I was a little late myself. Okay. So again, Amy, concept number 1, no lesions. Concept number 2, severely inflamed bladder wall. Concept number 3, very tight pelvic floor muscles. So I want to know, what are you doing for your pelvic floor? Because Hunner's lesions, there are 2 fundamental theories as to what causes Hunner's lesions. Number 1, it's a viral infection. Number 2, it's a result of neuroinflammation, a nerve being very, very irritated. So the question then becomes, how do nerves get irritated? Well, nerves are going to become very irritated if they don't have good blood supply. And so the legacy of tight muscles is a daunting legacy because it restricts blood flow, and then that could affect the nerves, etc. Oh, sorry, it's the incisions, they're bugging me. So Amy had blood clots come out after the hydrodistension for a day. Okay, that's significant. Did she cauterize the lesions? Did she? She said she didn't see any, but did she cauterize where it was bleeding when she was in there? Just out of curiosity? Dean says, how can we increase blood flow? Physical therapy. Okay, Amy said she had a staph infection afterward. It's gone now. So you had lots of lymphocytes and mast cells on biopsy. Girl. Yeah, I think we talked about that last week. Yikes. I had an infection actually on this side of my incision. They didn't tell me what it was, but I had a post-op infection too. So I feel you. I feel you, my friend. Well, we have to work on muscles because without working on the muscles, we have poor blood supply. And it's going to be very hard for your bladder to heal if it doesn't have good oxygenation and nutrition. So it's very, very important that you do the physical therapy. Number 2, the antihistamine. You've got mast cell disorder. Mast cell disorder can affect the bladder wall. That could be a source of that inflammation. So are you on antihistamines right now? Are you at least on quercetin, or even more so, are you on hydroxyzine? And Amy said she did not. She left it because my bladder was traumatized. I was closing my legs under anesthesia and you kept fighting back. Well, yeah, no wonder. This is hard. You know, Amy, you're where I was 30 years ago. And that is your bladder was toast, your muscles were toast, dry mouth, dry eyes, etc., etc. And okay, she said, yeah, she's on quercetin, Zyrtec, and Ativan. How are you now? Have you gotten at least a little bit better in the last 2 weeks? Are you better today than you were 2 weeks ago? Renee here says hydroxyzine really helps her bladder. All right, you guys on YouTube, you're being very, very quiet. And it says the chat disconnected, but that it reconnected. But is everything okay on YouTube? I'm looking at you guys. Yes, it's better, but still flaring. Okay, so tell us about that flare. So, where is the pain? Is the pain internal or external? Amy says she's blindsided. She was doing so good for years. Yeah, unfortunately, you had a very traumatic hydrodistension, and that's why a lot of people don't do hydrodistensions anymore. And when you look at the rationale in the AUA guidelines, when it came out, they were very clear on trying to reduce patient trauma because too many patients were being traumatized by hydrodistensions and never going back. And so they admitted that they had to change the way they were doing it to make it less painful, to encourage patients to work with their doctors. Marlia says, about a month ago, I had a yearly urologist appointment with cysto because he always checks me due to some blood, sometimes blood in the urine. I'm 74 with atrophy. I asked the nurse if he would give me some lidocaine before inserting the camera. She was rude and said he only gives lidocaine to men. What? They only give lidocaine to men because they have a prostate. Hello, we have something called the periurethral gland in our urethra, which is actually the female prostate, which is a homologue to the male prostate. Oh my God. You replied, but I have a urethra. Doesn't that count? I have that sensation too. And the nurse said, no, just men. Oh, screw that. Anyway, when he put the camera in, I jumped just a little. No biggie. I'm cool and calm. The urologist said somewhat snarky, boy, you are sensitive. I'm sorry, I was just asking for a little numbing. It felt cruel. It was cruel. There's no reason why they can't use a little bit of lidocaine in your urethra to chill it out and calm it down. The only thing that might be playing a role is that it was getting hard to get the lidocaine. There was a national shortage for the lidocaine, the Eurojet. So maybe they didn't have lidocaine, or maybe they were saving that lidocaine for more advanced cases. But man, I'm going to tell you right now, if I had a urologist or a urologist staff member who said they would not use lidocaine, I would not do it. I would not do it. It is standard of care to numb the urethra before you stick a cystoscope in. And I think that that's really unacceptable that they would only, I mean, do not even get me started right now on what's happening to women right now. She said they would only give the anesthetic to a man. Oh my God. Medical care has always been challenging for women. Always. You go to that fundamental research level, National Institutes level, they didn't even study women for decades. And, you know, then we got all laced with this perception, oh, she's just sensitive. You're so sensitive. With this perception, maybe we're just being emo. Maybe it's all in their heads. Ugh. Ugh. women, we must unite and advocate for ourselves. Period. End of story. There is a guy right now who had said, your body, my choice. How does it feel not to have any autonomy? I get to do whatever the hell I want to do to your body. No, this is not political. This is about women's rights. We must unite as women and say, this is not okay. You must tell your teenage boys, they may never say this to a woman. Never. And when you encounter any bias in any medical facility, you file a complaint. Why is a woman being treated than a man? Why is a woman being denied pain care? Oh, this pisses me off. Girl. Oh my God. My blood pressure might have just gone on a little bit. Let's take a deep breath in and out. I say that jokingly, I'm on meds. Okay. I think that's the thing that I'm just having that I'm really struggling with right now is just, I don't care about red or blue. I don't care about political party. I care about women. And I care about access to healthcare. And I don't want women to be minimized again. We fought so hard in the 70s and 80s for research. We have a new women's health research team at the National Institutes of Health for the first time ever that was signed into law or signed into existence like 2 years ago. I pray that doesn't go away. It's our obligation, this generation, to protect the women of our next generation. Oh, girl, boy, did that push a button. Amy said, yesterday, urethra is burning. Today, that's gone. Today, it's sharp pain inside. Okay, so Amy, sorry about that. Inside where? Is it pain inside your urethra? It is pain inside your vagina? Your left levator is tight. You have low back pain. Okay, cars sitting and sex makes it worse. So that's pelvic floor. Hydras have always helped me in the past, but honey, that's where you're confused here, because the hydro distension by itself does nothing to heal your body over the long run. A hydro distension is what I call is a destructive treatment. The way it works is when you stretch the bladder, you break the superficial nerves in the bladder. They get broken. So the pain nerves get broken. The frequency urgency nerve, the alpha afferent nerves, the C fibers, they get broken when you do the hydro. The problem is they always grow back. And fundamentally, the great risk is that more can grow back than you originally had. And so the hydrodistension is like a false positive. It's like, okay, I feel good. I want another one. But it's not doing anything constructive in the long run. It's not. It's just a very temporary thing that can minimize your symptoms for a very brief period of time, maybe 6 weeks, 2 months, 3 months. So you say that it always helped you in the past, but that's a fake out. It didn't fix anything. So the urethra burning, that could be estrogen atrophy, or that could be tight pelvic floor muscles, levator ani muscle. There are a couple of other things it could be too. Today you have sharp pain inside. And again, let me scroll down and let's see if we know. In your bladder, it feels more like cramps. The left levator and the low back pain points That's where I have my pain, left levator. That has nothing to do with your bladder per se. That's probably related to your SI joint or your hip or your tailbone. So that's physical therapy. And the fact that riding in a car, sitting in sex makes it worse, that's all muscle. That's not bladder. That's all muscle. You know, we end up in what I call the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor. They're both involved. They cannot not both be involved, but one is driving the other. For some people, this all begins after a bladder injury like chemotherapy. And because the bladder's screaming in pain from the chemicals of the chemo, the muscles get tight to protect you from that pain. And so therapeutically, we got to figure out what the irritant is, get rid of the irritant, give the bladder time to heal, give it some treatments that will protect it. Hoping then that as the bladder calms down, the muscles will also calm down. It's the pelvic floor patient that gets into a real bind, because with the pelvic floor patient, you really have no idea you have a pelvic floor injury. Your first symptom is frequency, urgency, pressure, pain. You're going UTI. I got a UTI. They give you antibiotics. They don't work. Urine culture comes back negative. They give you long-term antibiotics anyway. They don't work. Then they give you bladder meds and they don't work. And then eventually they go, oh, I hate to break it to you. I think you have this incurable bladder disease called interstitial cystitis. Here's the diet. Here's some Elmeron. Here's an antidepressant. I'll see you in 6 months. And legitimately you want to get better. So you do all that. The problem is that for the patients who have done it for, 6 months, a year, 2 years, 5 years, 10 years, 20 years, they still flare. Why? Because bladder therapies don't treat the underlying problem. Because the underlying problem is poor blood supply from very, very tight muscles. And that's me. That's me. And so I've always had a normal bladder when they've looked at it. Bladder therapies never worked for me. And when all the bladder research came in and the muscle research came back out when I was 48, realized I had symptoms at 14. And we checked my muscles for the very first time. My muscles were rock hard on my left side. My problem came from that. Sorry, hold on. This is what I do all day right now, guys. You just have to bear with me. I think a stitch is coming out. Renee says, no excuse, change doctors. Audrey says, agree. Renee says, get a woman doctor. Marlia says, I know, Jill. I'm so stinking done. I'm looking for a new urologist. I'm brave as hell, and I've never made a peep during my 5 cystoscopies. He says the bladder wall is perfect and yank the camera out. Okay, so Marlia, so here's the deal. Your bladder wall is perfect. You're done with bladder treatments. If you have a perfect bladder wall, then you have a healthy bladder wall. And so what does that mean then? What that means then is that there's something outside of your bladder causing your symptoms. So that's what we have to focus on. We have to focus on finding the other thing that's triggering all these symptoms. Could it be a fibroid tumor pushing on your bladder? Could it be tight pelvic floor muscles? Could it be central sensitization? Could it be black mold in your home? The good news here is you had it done. It's normal. There's no reason then to go down the bladder black hole. Now we have, and that's what our AUA guidelines say. Our AUA guidelines say if the patient is not responding to treatment, if the patient is getting worse rather than better, stop what you're doing, take a step back and revisit the diagnosis. So they did that. They looked at your bladder. You have a normal bladder. Now we got to figure out what else is going on there, because something else is going on. Something else is clearly going on. Renee says she has a better time with women doctors. Amy says it's bladder pain more like cramping. So Amy, bladder wall pain is very sharp and shrill. It feels like a razor blade. Pelvic floor pain is dull and achy and crampy. Amy says, if she'd injected the Kenalog, that would have helped. Agreed. You put some estrogen on the urethra. Excellent. I would definitely keep doing that. You have levator ani dysfunction and obturator dysfunction. Okay, you got to definitely work on that. And you have a history of Hunners, but the point is that they're gone now. And again, with your long history of very clear identifiable pelvic floor dysfunction, you're that chicken versus the egg again. Did this all begin because your muscles restricted blood supply, which created neuroinflammation? I think the priority now for you, where I would be putting my money for you, is going to be in hands-on physical therapy. And in the same sense, I would be doing something like Peora, Peaora, which is a supplement that can calm nerves down and reduce pain. Or I would be doing something like Bladder Builder, which might provide a protective effect in your bladder wall, a coating, give your bladder wall a little bit of extra protection so that those nerves aren't jacked up all the time. What has caused severe trabeculations? I have bladder wall and pelvic floor dysfunction. What do you mean trabeculation? Amy says, don't get me started on healthcare and women's rights. I have opinions and horror stories. Yeah. Amy says, I had the razor first, now onto cramping. Okay. Touching the urethra with cream triggered pain. Interesting. Well, you have to go where the evidence is, honey. I mean, so I've got a really good article on our website, blog on our website. Oh, you've got severe scarring probably from your previous treatment. Trabeculations does not come. So trabeculations is, I'm sorry, it's a thickening of the bladder walls or the presence of crevices in the left ventricle of the heart. So it's fibrosis of the bladder wall. It's just the wall. It's getting thicker and it's scarred. Audrey says, for me, it always comes back to diet. I had 2 installations. One gave me lower back pain for a year. I believe it was the moment after the treatment while I was still under anesthesia. I would definitely want to look at your medical record for that. Julie says, hi, Jill. I feel well. I'm trying, hun. I'm trying. See, I took my brace off for the meeting. You normally have this all compressed. You know what, guys? Let me just go get my little brace again. If I stick it on top of the incisions, it'll be better. Hold on. All right, now I've got a brace on. Oh. It's so annoying. Listen, I don't have any regrets because I knew having a mastectomy, getting the cancer out was important, but I'm sorry, the surgical recovery is brutal. It's probably the hardest thing I've ever had to deal with. It's just, and I lifted something 3 days ago, and I pulled all the sutures again. So that's why I'm just being so annoying right now. Sorry. Okay, Peora, Peaora. So Peora, Audrey said it happened to you too. Okay, so what is PEA? So PEA stands for palmitoyl ethanolamide. PEA has been studied extensively in Europe for a wide variety of pain conditions: acute pain, chronic pain, surgical pain, shingles, burning mouth syndrome, fibromyalgia, prostatitis, pelvic pain. Dozens of research studies with PEA. It is an endocannabinoid that helps to lower pain, nerve sensitivity, and pain coming from nerves. In the vast majority of studies out there, virtually every study I read but one, it significantly reduced pain. Now, I first heard about it 20 years ago from Dr. Lowell Parsons. There was a pharmacy down in Southern California that was that was importing it for IC patients, but it was just too expensive, and so it really fell off of my radar. You know, guys, hold on a sec. Hold on. I gotta go take a. Hold on. This is ridiculous. One quarter of a Norco with my friend right now. Okay. So again, I heard about this a good 20 years ago. Our challenge here is that 20 years ago it was very, very expensive, so it fell off the radar. Well, a lot had happened in those 20 years, including a lot of new research. And then in 2019, the European researchers started doing studies with pelvic pain, and then they did a study on IC, and they brought that study to the American Urology Association annual meeting, and it was breathtakingly successful. 87, if I remember correctly, 87% of IC patients in that study who took it for 3 months reported a significant reduction in their pain and discomfort, 87%. And the doctors who were there were just ecstatic that they could finally suggest something, a simple over-the-counter supplement with no risk of addiction, no risk of side effects, no burden of opiates, that they could suggest to patients. And so I took that study to Natural Approach Nutrition, which is the big company, the big supplement company that I think it's a top company that we work with now. And I said, can you make us a version of this based upon that study? And they did, and it's called Peora, or PEA 500. Now, thousands of patients use this now. I use it every night. Take 2 a night. And I think it's one reason why I've actually done pretty well, considering with all my surgeries that I've had this year. One of the original researchers, I emailed her last summer and I said, so what's the role of PEA now in Europe? And she goes, oh, it's a cornerstone. It's a cornerstone. Because again, when you think about phenotyping and how we started this, we now know that for 85% of IC patients, it's neuromuscular. So we've got to work on muscle health and we got to work on nerve health. And so the challenge with amitriptyline, Elavil, is that it has a ton of side effects. And you have to take like up to 50 milligrams or 75 milligrams to get to the really therapeutic dose. And very few people can tolerate the side effects of 75 milligrams of Elavil a day. Now you compare and contrast that with PEA, which has none of those side effects, is under $30 a month, and far more studies showing success with reducing pain. To me, this is a no-brainer. It's like, give it a shot. Now, you need to know. So, Jean, exactly, you take 300 milligrams of gabapentin 3 times a day, and it doesn't help. So, what our AUA guidelines would say is, if it's not working, take a step back, revisit the diagnosis. Why wouldn't that medication help? What have we missed? Is your pain, for example, coming from a tight muscle? Would a muscle relaxant make more sense? Now, so my phenotype is pelvic floor driven widespread pain. That's my phenotype. I am the queen of sensitivity. I hate taking anything. I go for the lowest dose of everything. I waited a year before I tried this. I let other patients try it before I tried it. I mean, a lot of people tried it right away. And again, because the IC study was so good, it was kind of like a no-brainer. I waited a year, and I was dealing with really severe skin sensitivity, this whole postmenopausal skin sensitivity. I was really struggling to sleep. I mean, I felt like I was being poked by pins. I'd have a big tub of CeraVe lotion in bed with me, and it was like I was chasing dry skin all night long. I just was being poked. And finally, I'm just like, oh God, I got to sleep. There's nothing to lose. And so I tried 1 Piora for a couple of weeks. I definitely think started getting better. Then I went to 2, and my skin sensitivity is virtually gone. I don't have the pinpricks anymore. But now I've got the damn incisions, and believe me, those incisions are sensitive, which is why I'm very committed to continuing my PEA. I think I've done very well otherwise. So Diane says, how does black mold in the house cause bladder pain? Black mold can trigger a wide variety of pathogenic responses in the human body. For some people, black mold makes them nauseous. For others, black mold makes them dizzy. For others, it gives them migraine. For some patients, black mold causes frequency urgency pain. And we did a big article on that not too long ago on our website and in our magazine. We had a patient, very interesting patient, who had really severe IC. I mean, like really severe. They'd moved into a new home, and everybody in the family got sick, and they all had different sicknesses. And for her, this was when her bladder pain and bladder symptoms started, and they were terrible, and nothing was working for her. And then finally, they figured out that the water heater was leaking underneath the rug, and the entire foam underneath the rug throughout the entire house was filled with black mold. This was a long-standing leak. It was leaking. They had black mold before they even moved. And it was just underneath the carpet, and the carpet was in every room, but almost every room. And when the team that came in to do it, when they saw it and saw how bad, it was a very, very severe mold situation. They had to immediately move out of the house immediately. And it took a couple months, but everybody got better. Everybody who was sick got better. I don't know if they ever went back into that home. And that's why, I think if you have a water heater, it needs to be in the garage or under the house. I do not want a water heater in a living space. Same with the furnace. My water heater and my furnace are underneath my house. We have a little the man cave down there. It's in the man cave. Belle says, my bladder was injured by chemotherapy. I'm taking bladder builder. Is that what I should, or should I be taking Peora? Belle, how old are you, hun? I mean, bladder builder has PEA in it. And, you know, the challenge is when you've gone through chemotherapy, I mean, there's two things you have to think about. You got to remember, number one, that if you are in estrogen atrophy, so you're okay. And honey, when did you have the chemo? When did you have the chemo? Was it this year? Last year? So okay, so I'm waiting for her to answer. So you got to remember, okay, 10 years ago, it's 62. Okay, so at the age of 62, you were in estrogen atrophy. So what does that mean? It means that nice thick coating of mucus that normally protects the cells of your bladder wall was not effective anymore. It was thin. The bladder has something called the GAG layer, the glycosaminoglycan layer. So your bladder's like your mouth. It's a hollow organ that's wet. And it's supposed to be wet. That wetness is actually how your bladder defends itself. But mucus in your bladder, the GAG layer in your bladder, is estrogen dependent. So when you're young and have a lot of estrogen, you have a lot of mucus. But once you're in your late 40s, 50s, you're in estrogen decline. You're in estrogen atrophy. Therefore, you don't have a lot of mucus. Therefore, your bladder can't defend itself as well from something as simple like coffee. But if you have to go through chemo, holy hell, mother of God, now we're putting toxins into the bladder that is just wide open because you don't have the mucus. And so your diagnosis would be genitourinary syndrome of menopause based upon your age and chemocystitis based upon the chemotherapy. And for anybody who's listening to this or watching this, so not all forms of chemo cause bladder pain, but some do. And there's actually a medication called Mesnex, Mesnex. Mesnex eliminates the toxic byproduct of chemo that damages the bladder. And so the minute you have chemo, the minute you start feeling bladder sensitivity, you always want to call them and say, hey, my bladder hurts. Can I have some Mesnex? Would Mesnex help? Because Mesnex would stop the production of that irritating metabolite. I was working with a young guy, though, who was going through chemo, and he'd already had chemo for he was almost done with his chemo, and it was hurting his bladder terribly. And I told him about the Mesnex, and he asked his doctor, and his doctor was like, oh, it's not that bad. It's like, honey, you don't live in this freaking body. It's bad. Give me the freaking Mesnex. Got to remember, doctors are taught to diagnose by observation. And if they've never had bladder pain to the degree that you have bladder pain, they really don't get it. They don't know the suffering that you are experiencing in the middle of the night because they've never personally experienced it. And I think that's so, that's an important concept. And the second important concept is understanding that a male doctor, a male gynecologist or urologist, with all due respect, they've never had menstrual cramps. They have no depth of experience personally to understand how bad pelvic pain can be. All they can do is listen to you. And hopefully they will listen to you. But as we learned earlier, we've got patients now who are having major surgeries and they're being denied all pain care. And again, I'm just going to say it. When I had my hysterectomy, I told them flat out, if you're not going to give me pain meds, I'm not doing the surgery. I will go to somebody else because I am not going to have major surgery without pain care. I mean, I just took a quarter of a Norco. You saw me do that. My pain right now, but before I did that, it's already a little bit better, was like an 8 on a 10. And I'm getting stabbed right here, because I got stitches coming out. My body's rejecting the stitches. Thank God I have that little bit of Norco. Nobody can accuse me of becoming a drug addict if I take 1/4 of a Norco once a month. Come on, I'm 4 months post-surgery. I lifted something really bad. I pulled the stitches. I've taken a quarter of a Norco like 4 days ago and a quarter of a Norco today. Am I a drug abuser? Hell no, I'm not. I'm a post-surgery patient. And I will fight for that right. Getting back to Belle here. Hold on a sec. Actually, okay. And Belle, because her cancer was estrogen dependent, they wouldn't give you vaginal estrogen until 2 years ago. Well, it's really just in the last 5 years, Belle, that we had really, really good research showing that topical estrogen is considered very safe and does not pose an increased cancer risk as compared to oral estrogen. I will be perfectly honest, though. I had an estrogen-dependent breast cancer, and I have cut my topical estrogen down by like half. The doctor didn't tell me to do it. The oncologist said it was all safe, Jill. You can use your topical estrogen, but I'm sorry, a little freaked out having cancer. So I use it. In fact, I used it this morning, but instead of doing it 3 times a week, I'm doing it like once or once and a half a week. Amy says, pain management wants to start me on a ketamine infusion for nerve pain. I'm worried for my bladder. Anesthesia gave me ketamine for my last hydrodistension. Well, again, I think the hydrodistensions are not serving you the way you think they're serving you. And it's the hydrodistensions that might be causing a lot more of this excess pain. Because any benefit you get from a hydrodistension is short term. And they're not working for you. You've had to have more. So, I mean, if you don't have lesions and they don't think the lesions have come back, there's kind of no reason to do the hydro. If the doctor can do what we call a narrowband imaging cystoscope, they can take a quick peek in your bladder, look for lesions, and pull it out without stretching your bladder. Now, ketamine is definitely a pain management option. The challenge with ketamine is that once you go past a certain point, and every patient has their own point, kind of the point of no return, ketamine actually damages the bladder. So we call it ketamine cystitis. And I built a website on it, ketaminecystitis.org. I mean, we've been working with ketamine patients for the last 20 years. Generally, it's addicts who are using ketamine who end up doing higher and higher and higher doses. And the ketamine kind of acts as an industrial solvent and does a lot of damage to their urinary tract, just damages the kidneys, damages the ureter, really, really damages the bladder. But that's high doses over time. Doing a short-term course of ketamine would be interesting. But what I would just say to you is the minute you have any extra bladder symptoms, I would cut that sucker off. You can go over to ketaminecystitis.org and look at the research. I've got all the research except in the last couple of years. I don't know, when did I update it last? Maybe 2 years ago. Also, another way that people use ketamine, and this is something that Robert Eckenberg has really been talking about, is how important it is that we treat the skin also. If we got nerves that are irritated, that irritation is going to show in the skin, and you're going to have pins and needles, areas of numbness, et cetera, in the skin. And so it's really important that we act to calm excited nerves where we find them. And so using a lidocaine cream down there to calm and numb that nerve is a viable option. Or they can do something called an Amibac cream, which is a combination of amitriptyline and baclofen, or they can add ketamine to that, and then the ketamine would also help to reduce some of that pain. Right, I just virtually tore my fingernail off. Holy moly! Bell said the doctor only gave you gabapentin and Elavil. Horrible, terrible side effects. That's why the PEA does not have significant side effects at all. So I think that this would be a very interesting thing to consider adding to your protocol. Renee says, I have never experienced no pain care. I have, definitely. And I'm very verbal about it now. I'm very aggressive about my pain care now. Stacy said, I started IC during menopause 4 years ago. You're almost 61. Hey, girl, welcome to the 60s. 61 is the new 41. So technically, I'm at 44 right now. I have lots of vaginal pain. I'm working with a functional med doctor for my thyroid, and he took me off gluten, dairy, corn, sugar, and soy. My inflammation markers are all down, but the IC didn't get better. Hydrodistension seems to be my only relief, but it only lasts a few months. My adrenals aren't working well, so we are working to get those going so I get more hormones. They say the bladder is shrinking. What's your advice? Stacy, you're an estrogen atrophy patient. You are a genitourinary syndrome of menopause patient. That's not a disease, honey. That's estrogen atrophy. And so what does that mean? What that means is the loss of estrogen is directly affecting the health of your skin internally, in your vagina, on your vulva, in your urethra, in your bladder. And so, what if you put a raisin in a glass of water, what does it do? The raisin absorbs the water and plumps up. Well, that's exactly what the skin cells do when you give them estrogen. The single most important treatment is topical estrogen. It's the most natural thing you can do because when you give that skin estrogen, it immediately starts to produce mucus, which you desperately, desperately need. So it's your body's own natural mucus. So from the vaginal pain, are you using any topical estrogen products? An estradiol cream? Because, listen, getting you off of gluten, dairy, sugar, soy, all that sort of stuff, that's not going to fix estrogen atrophy. Yeah, that might reduce some of your overall systemic inflammation down, but that's not going to repair the structural integrity of your bladder wall. That's the fundamental problem with estrogen atrophy GSM, is the structural integrity of your bladder wall has changed. So if we want to improve it, we have to give it what it's missing, which is estrogen. Now, even with estrogen, the challenge here is you're never going to have a 20-year-old bladder again. You have a 61-year-old bladder that's a little bit better now that you're on estrogen. That's great. But your bladder's ability to defend itself is compromised. And so if we want a little bit of protection in the bladder wall, you could start with a chondroitin-based supplement like Bladder Builder or Bladder Rest or Cystomend or Cystoprotect, because chondroitin acts to coat the bladder wall. And this is where the old IC treatment Elmeron shined, because Elmeron was a Band-Aid. It was a chemical Band-Aid that coated the bladder. But of course, now we know that Elmeron is linked to blindness and severe retinal disease and inflammatory bowel disease. It's associated with that. And so Elmeron's pretty much off the table for many patients, if not most patients, in my opinion. So instead, chondroitin is believed to have a similar effect, and liquid chondroitin is put into the bladder as a treatment for IC in Europe and Canada anyway. So instead, we're trying to build up that chondroitin content with a supplement instead. Of course, a lot of it's destroyed by digestion, but it's basically one of the first things you could try. The next thing you could try is a heparin instillation. Heparin to coat the bladder, lidocaine to calm the nerves down. So that addresses the lack of coating, but the challenge with that is you have to keep doing them. So, we can't turn off aging. We can't turn off estrogen atrophy. The good news is it's not a disease. There's no disease happening. It's just dryness. Over on the Reddit IC board, in the IC forum over on Reddit, there was either a doctor or a nurse practitioner who was posting specifically about this. And I have been preaching this for the last decade because it pisses me off that there are millions of women who are told that they have an incurable bladder disease when in fact it's simple. It's estrogen atrophy. And it's not just when you're older. It can happen when you're 18 and start birth control. If that birth control is too strong and it shuts your estrogen levels down, you go into early menopause. If you're on Lupron for endo, you go into early menopause. Amy says 4-hour infusions 1 time a week for 6 weeks and then 1 every 4 months is the plan. Well, honey, I don't have any experience with an IC patient doing that. And so the proof is in how you do. I think that I think your nervous system is wound up terribly from all the hydros and all the treatments that you've had. And so it's probably going to take something a little bit more aggressive to try to calm things down. So if I were in your shoes, would I consider doing a ketamine infusion? Yeah, I think I would. But I would be very, very vocal. I would really see, how do you feel as they're doing it? Hi, Judy. Yeah, Judy, we started at 1 Pacific and actually started at about 1:15 because I was having internet problems. So yeah, got a little bit later. Okay, so anyway, getting back to this ketamine infusion, I think you're just gonna. I would just have a really clear discussion with the infusion center and say, I need you to be attentive. I've never had this before. If I feel anything funky, I want you to turn it off. I need you. I just don't sit there and take it. If it doesn't feel right, it doesn't feel right. Raise your hand, raise your voice, and say, I don't. If you don't like it, say, I don't like it. I don't feel well. I want you to stop. Because ultimately, it is your body, and this is an option. But there's always a chance that you might feel better. And if you feel better, great. If it will act to calm your nervous system down, good. It's just no way anybody can guarantee to you it's going to work for you. That's the scary part. You just have to try stuff. Lori says, what is actimine? ACDIMI? ACDIMINE. Is it with a T, not a D? Pseudoephedrine, actamine, ACTA, is an ephedrine-based product for colds. Yikes! I couldn't touch that with a 10-foot pole because that can make your heart race. Stacy said they also found ochratoxin A. All right, let's see what that is. Produced by certain molds that can contaminate food and water. Found in cereals, coffee, dried fruits, wine, grape juice, spices, and licorice. It can develop when crops are stored or dried improperly. It can contaminate water, damage homes and heating ducts. Oh, it's produced by Aspergillus. Yikes. It's considered dangerous to humans and animals. It can cause kidney damage, can affect fetal development and the immune system. It is considered very toxic if swallowed and can irritate the skin. It produces nephrotoxicity and kidney tumors in a variety of animal species. Yeah, that's shocking that they found it, and I'm glad they're treating you for that. Yikes. Amy says, I want my bladder back to pre-hydropane before I try the ketamine. Well, Amy, you can always rely on the fact that the human body is trying to heal you right now. Healing never stops. The challenge is we often get in the way. And so I think that you've got to do everything you can to create an environment that will support healing of your bladder. That means you got to be really pristine with your diet, no caffeine, nothing neurostimulatory, nothing acidic. I mean, you just got to go back to eating simple, fresh food, whether it be chicken, whether it be turkey, whether it be zucchini or potatoes. Just simple, fresh, healthy food. No fast food, no junk food, no pre-manufactured food. We got to get back to how we were eating before food became industrialized and profit centered. Stacy, I would really love to keep in touch with you on your ochratoxin A because that's really worthy of an article. I'm very, very focused on finding the rare and more unusual causes of pelvic pain and bladder pain, and that's one of them because for those patients who don't fit into a specific phenotype, we're not going to stop looking. We're just going to look for rare and more unusual things. That's an example. I had a patient call a couple months ago who her symptoms started after she did 6 weeks in Panama or Costa Rica. And she was doing a lot of water diving and she was in the water a lot, including in brown, muddy rivers. And she had a parasite in her bladder. And so, once they found the parasite, then I treated that, her symptoms went away. Judy W says, I just found you, checked in at 12. Did you start later? Yes, I start at 1 Pacific. At 1 Pacific. And we usually go from 1 till 3 or 4 or 5, depending upon the people have questions. And then, of course, most of them are recorded. The only time they're not recorded is if there's a problem with the feed or I forget to turn it on. So all the recording is on there. And I've only ever deleted one episode, and that was because I accidentally revealed one of my important passwords. I was like, uh-oh, deleted that right away. Stacy said it. Do you sell lidocaine cream? I don't, but you can get it anywhere at any drugstore. And your doctor can give you a prescription for a lidocaine jelly. You're using topical estrogen. It doesn't help much. Okay, I listen. A lot of women say that topical estrogen doesn't help much. Topical estrogen is not a treatment for your symptoms. Don't assume that because you're starting topical estrogen that it's going to make your frequency, urgency, pressure, pain go away. It doesn't work that way. Topical estrogen is all about getting your skin healthy. So don't stop the topical estrogen because you think it's not working. The question is what does your skin look like? Is your skin improving? Because the healthier we get you skin, then the better your skin is going to be at protecting itself and pushing away infection and pushing away other irritants for your bladder. Audrey said it burned you. Anytime topical estrogen burns, that means your skin is very dry. You got to ride through the burn. It just, every subsequent time you use it, the burning gets better and better and better. And that's because every time you give that skin, the cells start, I mean, that the skin estrogen, the cells start to plump up and they start to produce mucus. So don't be afraid of that burning sensation. I had the burning sensation too. 2 weeks later, it was gone. If I don't use my estrogen for 2 weeks, it comes back because that burning is a direct reflection of the quality and health of your skin down there. Amy says the lidocaine heparin solumedrol installation really helps. Most doctors have their own blend. True, very true. You know, Amy, I guess the other thing I would ask you is have you, I mean, because you're in a weird situation. And it made even weirder by the fact that you had a post-operative staph infection. That was you, right? I think if I were in your shoes, I would want to do a next generation DNA urine test to see if there's anything else going on in there. Is there any chance that the antibiotics that they gave you for the staph, could that have created a yeast infection in your bladder? Because yeast infections in the bladder hurt like hell. Take it from somebody who's been there. And a typical urine culture does not look for candida. It would be absolutely fascinating to do a next generation DNA urine test to see if there's anything else funky in there, any sort of pathogen that might explain why you're struggling so much after this hydro. I mean, listen, you had a nosocomial infection for the staph. Is there any chance that there's a second nosocomial infection that might be lower grade that's there now? Lori said, my installations really helped me. I also take pre-leaf and hydroxyzine. Okay. They never help me. And so again, that's why we have phenotypes. So a bladder installation is going to work for patients where we have superficial bladder wall issues. Bladder installations will not work for somebody with widespread pain because the widespread pain phenotype is about the central nervous system. So, I mean, this is where we are, and it's exciting and it's good because we're finding better treatments and we're finding more effective treatment. Really good things are happening right now. Hey, JD. JD says, wonderful to see you. Thank you so much. Thank you. Really appreciate that. JD says, why is Hyofen off the FDA list of treatment? Hyofen has not been on the FDA list of IC treatments in a decade or longer. I don't remember Hyofen being in the very first AUA guidelines, and those were released in 2011. It has not been positioned as an IC treatment for like 20 years. So Hyofen, just for people who don't know, it's a combination med that treats a variety of urinary symptoms such as painful urination, bladder discomfort, and urgency caused by infections or irritation. It is not an antibiotic and cannot be used as for UTI. I really haven't, at least in the last decade, it just hasn't come up a lot. I mean, I'm thinking about all the IC courses that I've taken and at the conferences and things like that. It just doesn't come up anymore. You've been on it for a few years. It helps so much. Good to know. I mean, So hyofen is methenamine blue, benzoic acid, phenyl salicylate, and hyosamine. So basically what that means is it's got aspirin in it for reducing pain. It's got hyosamine as I think it's a smooth muscle relaxant. It's got the methylene blue. One of the ingredients is about suppressing infection. Again, we have to understand your phenotype. I mean, you've been using it for a few years, so yeah, it's giving you relief, but it's not repairing anything. Because if it was repairing it, you wouldn't need it again. And that's where we are today. We're really trying to find underlying causation. When we find the underlying cause of your symptoms, we can focus on that so you don't have to take hyofen for the rest of your life, or you don't have to do an antidepressant for the rest of your life. I mean, I think it's fantastic that it's helping you, but it's a false flag because it's not repairing anything because you're still having symptoms. JD says true. Yeah. So I think it'd be very interesting to phenotype you and figure out what your phenotype is. If you want to do that, call me this week because I do it all the time with patients on the phone. Jean says, I get heparin, marcaine, and an anti-inflammatory, really helpful. Okay. Amy says, I'll add the PEA and the chondroitin. Yeah, you can find those in the IC Network shop, hun. I'll stabilize my mast cells too with quercetin. I'm waiting on the micro. Oh, you're waiting on your microgen results now. Okay, cool. You need a company that will test virus. The one I did is fungal and bacterial. You know what? Call Microgen and ask them. Your urine culture says mixed flora. Okay, well, once you're over the age of 60, you're going to have a lot of mixed flora because the biome changes. The question is, what's in that mixed flora? So when you get it, let me know. Jean says you agree with Lori. Your hair is really thank you guys. I spent all summer thinking I was going to lose it with chemotherapy. And I had this emotional breakdown because like the only thing my self-identity is a lot about my hair. And the fact that I was teased so badly as a redhead when I was a kid. And so now as an adult, it's important to me. I love it. And I thought I was going to lose it all. And I thought, okay, listen, I've had super short hair before. I can go bald. I can grow it out again. But inside I was screaming, just in fear of chemotherapy so badly. And so thankfully, my pathology results did not find cancer in my lymph nodes. In fact, they got it all, and it was 1.8 centimeters away from my skin and away from the surgical margin. And so they said, you're cured. We believe that we got it all. And when I found out that I didn't have to go through chemo, that I was going to get to keep my hair, that was just, and so now I'm just like growing it out as a banner to breast cancer. It's just like, even though I will say I've lost a lot of it. I probably lost a third of it in the last 4 months from stress. But I had a colleague say to me, you need to cut your hair. It's starting to look like a hippie. And I'm like, hey, this is about surviving cancer. I'm going to keep it as long as I want. And then I'll cut it Usually I cut it up to my shoulders once every 3 years and I let it grow out. But right now, this is a testimony to survival. Knock on wood. Amy, call me, when you get your next gen results, call me. I'd love to hear what it is. Me over here hoping you have an infection like most IC sufferers. Well, I mean, it can be complex. There can be lots of different things that can trigger the bladder besides infection. Like, again, like a fibroid tumor pushing on your bladder. You say it feels like an infection. It's kind of worse at night and early morning. Okay. Thank you, guys. Renee says, I love hippies. I was one. Man, I feel like a hippie right now. And which is ironic since I was a very conservative kid growing up. I'm not conservative anymore. Now it's free love, baby. It's about women's rights. It's about free love isn't the right word. It's about putting people in front of money and caring for others. And, I like to teach the world to sing perfect harmony. It's like, that's where my brain is right now. Judy says, is the next gen number on my website? No, it's not, but I can get it for you. Hold on. I actually stopped working with that company 2 years ago directly. And that was just, everything's changing with the internet. They wanted to do a different type of advertising than I could give them. So that's okay. Their phone number is 855-208-0019. And that's Microgen. So 855-208-2019. And the test that you could do. So see, they have a Candida panel now, testing for 5 species of Candida. They have a sexually transmitted disease. They've got HPV, which is a discrete at-home test. They've got herpes tests. They've got an oral HPV test. But the one you're looking for is going to be the UroKey test, KEY, UroKey, which tests for bacteria and fungi that can be causing UTI, IC, and bladder pain. At the same time, you can also do a vaginal test. I've done both of them. So there's a UroKey and there's a woman's key. What is the woman's key? Oh, the woman's key combines a urine and a vaginal sample, whereas the UroKey is just a urine sample. Hey, man, it's data. It's facts. You deserve more than a guess. You deserve facts. It's a valuable piece of data because our big problem here is that it feels like an infection. So many patients are like, it's infection. It's infection. Give me antibiotic. And you're right, it could be infection, but if it's a fungal infection, the antibiotics will just make it worse because you need antifungals instead. And if you take antibiotics, you kill the bacteria that eats the fungus. So this is all about data. If you believe you have an infection, like we had a patient who literally told her doctor, I will do nothing but antibiotics. It's infection. And the doctor said, no, I'm not giving you any more antibiotics. You don't understand the damage it's doing. And she called me and she was really upset. And I'm like, honey, listen, he's right. Taking antibiotics indiscriminately damages your biome very, very badly down there, including in the urinary tract. But listen, if you think you have infection, I say, let's explore that. Have a next generation DNA urine test. That'll prove it once and for all. And if that comes back positive for something like enterococcus or micrococcus, then You got all the ammunition you need to ask for more antibiotics. But if that comes back negative, then you're done. No more antibiotics. And if it shows a positive fungal infection, then it's going to be antifungals, not antibiotic. So I don't have an issue with anybody doing a next gen test. I think it's important. Now, Belle says her pelvic pain starts after having a bowel movement. You get bladder urgency. Oh, girl, we could talk about bowel movements for hours. Okay. So, Belle, my question to you is when you have a bowel movement, are you straining? Are you pushing it out? If you're straining, then that's why you're having bladder symptoms because if you're pushing hard to have a bowel movement, those muscles are getting very, very tight. I mean, listen, the next time you have Montezuma's revenge, okay, the next time you have a bout of diarrhea that's unexplainable, and so you're on the toilet, you're having diarrhea, you're done, can you pee afterwards? A lot of times you can't because your muscles are cramping and they're tight. You have to wait 10 minutes for the muscles to release for you to be able to urinate. Okay, so you say you're not straining to have a bowel movement. Okay. So then what would we do next? Um, okay, couple of things. Bill, this is going to sound bonky. Okay, this is going to sound really weird. Do the bottom of your feet ever tingle before you need to have a bowel movement? You ever feel kind of just like something a little funky in the bottom of your feet? I do. Started in my 20s. There are moments when, not all the time, but occasionally, I will be sitting and I will feel the bottom of my feet start to tingle. And usually within 10 minutes or so, I have to have a bowel movement. Then I go to the bathroom and the tingling goes away. That is a proximity thing. You know, the challenge in the pelvis is there's a lot of nerves going in a lot of different directions down there. You know, your pelvic floor is kind of a woven basket of muscles that go from left to right, front to back, low to high. Well, there's a spider webbing of nerves in there too. Okay, wait. Okay, guys. She says my feet burn occasionally, but not before a bowel movement. But that's important. Isn't that weird that I asked you that question? Because that's a sign that something is pushing against the nerve in your pelvis. And so for me, that happens if I have, and you guys just, I'm sorry, bear with me. You know, I'll talk about anything, no shame. That's if I have a hard, chunky stool hanging out in my rectum. And as that's moving, it rubs against a nerve that goes down to the bottom of your feet and it causes that foot pain. And then as it continues to on its journey, eventually it's going to move by and stop putting pressure on the nerve unless you become constipated, which is a whole nother story. So proximity matters. So you can have issues in your pelvis from hard stool pushing on nerves. How else would a bowel movement trigger urgency. The nerves are shared. We call it neural crosstalk. So we had a study several years ago, which we called the pepperoni pizza algorithm. So we know that patients who are constipated have more bladder sensitivity. We know that. That's well documented. So the question is why? Because they're separate organs. Yeah, they're right next to each other, but they're separate. So why would that happen? And some researchers have done a lot of different testing of the nervous system to try to understand it. So one of the studies they did is they irritated the bladder with pepperoni. They called it the pepperoni pizza algorithm. And they were able to prove is that if you chemically irritate the bowel, the bladder will also show signs of irritation. And vice versa. If you irritate the bladder, the bowel will show signs of irritation. So what is that all about? That's called neurologic crosstalk, neurocrosstalk. So what they did then is they put one radioactive tracer into the bladder nerves and a separate radioactive tracer into the nerves of the bowel, and then they followed them. Where did they go? And what they found is that the radioactive tracers merged at the spinal cord where the nerves merged. So literally, they merged together into one distinct nerve at the spinal cord. So when nerves merge together, they now talk to each other. And if that nerve group in one area becomes irritated, that inflammation spreads to everywhere that nerve innervates. So that could be playing a role too. Amy said, it's pressing on that nerve bundle. Happens to me. You can even press on my low back and I feel it in my urethra. Excellent example, Amy. Excellent example. And Belle, I'm going to tell you right now, that feet burning is fascinating. And if I were to guess, I would think that you probably have tight pelvic floor muscles squeezing the sciatic nerve or the pudendal nerve that's causing your feet to burn on occasion. I bet you that correlates with muscle tension. Have you had a pelvic floor assessment? If you go to have a pelvic floor assessment, you need to make sure that you tell them about your feet burning. Dean says, does anybody have mast cell activation syndrome? Lots of patients have mast cell activation syndrome. When I started this meeting, I did our partial presentation on phenotyping, and Dr. Curtis Nickel up in Canada believes that there are 9 distinct groups of IC patients, each with their own treatments, one of which is an allergenic group, which would correlate with mast cell activation syndrome or allergies. So it's definitely possible. Definitely possible. You're waiting for an appointment. You can't get in until Christmas Eve? Well, that's not far. You know, honey, that's not too far away. That's 6 weeks. Just make the appointment. Just do it. Make the appointment on Christmas Eve, because then at least, you know, I mean, that's what we've got to do right now anyway. I mean, with our medical care right now, because we don't know what's going to happen in a year. We don't know what's going to happen to the state of healthcare in a year and our insurance in a year. We just don't know. And so get everything done now if you can. Try to make your appointments now if you can, because we have to wait and see changes that might be coming to health insurance. We just don't know what's going to happen. And that's very unsettling for, you know, like I said at the start of the meeting, listen, 50% of the IC patient population, they're ecstatic right now. They think everything's going to get better. And the other half of patients think, oh my God, this is terrifying. What will I do if I lose my health insurance? And it puts all of us in a very, very delicate situation because listen, one side doesn't invalidate the other side. There are legitimate reasons to be concerned, and there are legitimate reasons for some people to be happy. We don't invalidate each other, but we have to respect the fact that there are a group of patients living on disability, living on Medicaid, that are honestly terrified right now about what's going to happen to their medical care. And that's completely legitimate. And that's not political. These are people who have been on disability for years. They're struggling to buy food. They're having to choose between buying medications and buying food and all that sort of stuff. Those are the ones who are terrified. And I'm terrified for them. Amy says, I'm so worried for my healthcare Medi-Cal. I already drive 90 minutes for care and I'm disabled too. I'm not going to invalidate that fear. That's a legitimate fear. I've got people calling me this week terrified. And so we have to wait and see what happens. We have to wait and see if calmer heads will prevail or if there's an alternative plan that will miraculously provide better health insurance. We don't know. None of us know. So get what you can get done. And then it's going to be one day at a time. We all have to be very proactive. We all have to make sure that we're embracing mind-body medicine. We're embracing self-help. We're eating well. We're not wasting time drinking coffee. We're not drinking alcohol. We have got to put our health front and center. We just have to right now. And we should be doing that anyway. Like, did you guys know that sugar causes cancer to grow? I didn't know that. I didn't know that. And I was listening to, who was it? It was somebody who was diagnosed with throat cancer. Oh, no, it was Michael Whelan. Michael Whelan, who's been dealing with throat and esophageal cancer, and it came back. And they looked for sugar markers on his tongue to see if the cancer was back, and it was back. I did not know. And then, so, yeah, I just did a deep dive. What, sugar causes cancer? Really? And, the people who know, and they go, yeah, we've known that for years. Renee said, I heard it. I'm in a struggle with sugar. I was off of it for about 4 months. I'm doing a lot more honey than I am sugar, but I still put a teaspoon of sugar in my tea in the morning. But I'm not eating cookies and I'm not eating ice cream and I don't eat candy. But, you kind of live in this post-cancer world of going, well, this bite caused it to come back, which sucks. Amy says, I hope the health insurance I have is left alone or made better. I completely agree. Marlia says, Jill, you are amazing. Sometimes my feet tingle before a PM. Not always. Isn't it weird? But get this, I'm petrified every time I have to go to the doctor. And while I'm in the waiting room, the bottoms of my feet tingle and itch uncontrollably. And at bedtime, my whole body feels like I'm getting stung by bees everywhere. And then my whole body feels like I have restless legs all over. You have Hashimoto's, autoimmune thyroiditis, Sjogren's, fibro. My whole body gets hot and flushed when I get scared or upset. I only sleep about 4 hours a night. Menopause to the max. Girl, have you tried this yet? Between this and pelvic floor physical therapy, that either one of these have the chance. This would calm nerves down, and the pelvic floor physical therapy would, because you got to remember, when you're under stress, you go into fight or flight. The very first muscle group that gets tight in fight or flight is your pelvic floor. So of course you're going to have tight muscles at a doctor's appointment. Of course. And so making sure that you're doing everything you can with physical therapy, making sure that you're doing things that calm nerves down, and doing really good anxiety management, which is very hard right now because there's a lot of anxiety in the world. Again, I'm like checking in on my anxiety level, and my level of calm is non-existent right now. There's just so much stress. And the only time and again, it's not just work stress, and I talk with patients in pain all day, so I have to have really good ways to protect myself at night, and because I love my job and I think I'm pretty good at what I do, but I have to take responsibility for my emotional health. And in the old days, I would just go play computer games, but I find computer games very stressful now. So now what I'm doing is I'm painting. Like I get the most advanced paint by numbers you can get. Meticulous. They're not children's. These are meticulous, tiny, tiny areas that you paint. And I can just sit and paint for an hour or two and just chill. And that's my meditation now. I did it this morning before I started this meeting, as a matter of fact. Diane says, what does a person do if their urologist doesn't do a next generation DNA test or won't treat the results you get? Do they have doctors through their website that do telemedicine and can prescribe med? Yes, they do. They do. They can help you find a doctor to interpret the results and potentially provide treatment if necessary. It's tricky. Medical society right now does not want to do next gen testing because health insurance companies don't want to pay for it. Urine cultures are cheap. They're cheap, but they're flawed. They're fundamentally flawed because when you do a urine culture, it will only grow out the bacteria that eat the culture medium. So they are completely self-limiting. And the problem is different bacteria eat different cultures. And so a urine culture by its very nature is going to miss 90% of the potential bacteria in there. Infectious disease specialists live on next generation DNA urine testing because that finds the rare, more obscure infections that could be causing problems. So when health insurance won't pay for it, and health insurance tells doctors they won't pay for it, then doctors are like, well, then I guess we can't do it because I'm not going to pay for it. So there's this fairly challenging hurdle. And yet Dr. Curtis Nickel actually at the American Urology Association meeting 4 or 5 years ago did the keynote presentation to hundreds and hundreds of doctors. And he just flat out said, guys, this is the future. Urine cultures are flawed. Next generation will find everything because it doesn't try to grow bacteria out. What it does is it blends up your urine and breaks them all, breaks them in half and flushes their DNA out. And then it looks at the DNA of what it finds to figure out what's growing in there. And when they find what's growing in there, so basically they get these big long strings of DNA, they identify it, and then they compare it with these big international databases, trillions of bacterial code in there. And that will tell them the species of the bacteria, and more importantly, it will tell them drug resistance genes. And so, again, I was working with a patient, we just did this like 2 weeks ago. Man, she had some really unusual drug resistance genes. And what's funny for me when I've had it done, and I think I have it, here, hold on. Is it in here? Yeah, okay. So look, here is this was a next gen test that I did 5 years ago, and it was a vaginal swab. Okay. And okay, so the first thing I want to show you, okay. And there's no social security number or anything here, so we're good. So here are next generation test results. Look at this first line, resistance genes detected. Every time I've had a next generation test done, that's what it finds, that I am drug resistant to all aminoglycoside antibiotics. Okay. Now, guys, I'm a pharmacologist. My degree is in drug development. You can damn well know and believe that I am aware of everything I've taken. And I haven't have a very good memory for that. I have never in my life voluntarily taken an aminoglycoside antibiotic. Never. Never. The only way I could have been exposed to that is if somebody gave me a shot of that when I had my hysterectomy or some sort of surgical procedure. Or I got it through food. Might have got it from a piece of meat. You know, there might have been a cow that got slaughtered that had an aminoglycoside. So anyway, so the cool thing about the next generation test is it tells us what we cannot use. I can never use an aminoglycoside. Never. The other thing too, so if we look at this, what did it find? It found Lactobacillus gasseri, it found Prevotella, it found Staphylococcus, and it found Gardnerella. Now, why did I do this test? Why did I do this? I think I did it after my hysterectomy because I did it after, I did it after I had my hysterectomy in May. And I did this in June. No, I had my hysterectomy in April. So there was a symptom that I was baffled by. I don't remember exactly what it was. Okay. And then in this part, it lists like penicillin. Penicillin will kill the lactobacillus and penicillin will kill the strep. But it will not kill the Gardnerella. And so then it has a different antibiotic here, an extended spectrum penicillin. And it's got amitriptyline. I mean, it's got, what is that one? Aminopenicillins, and then Flagyl, and then Cipro, and then cephalosporin, clindamycin, etc. So this is exactly what the test results look like now. And it really didn't find a lot. It only found 3% Prevotella, 2% strep, and it didn't even provide a percentage for Gardnerella, but it did find 92% Lactobacillus gasseri, and Lactobacillus gasseri is in fact a good bacteria. So there was no reason to treat me. I did not do antibiotics based upon this test. Amy says, I miss coffee so much. I was able to have it prior to this hydrodistension. Yeah, Amy, oh, honey, listen. You're getting older. Your bladder's ability to defend itself changes as we get older, as estrogen levels decline. Many women can tolerate coffee in their 40s, but in their 50s, that one cup of coffee in the morning, they can't do it anymore. It's just too hard on their bladder. And so that's when you do an herbal coffee. Well, you either do a true low acid coffee. If you go into the IC Network shop, we sell Bella Rosa low acid coffee. It tastes fantastic. It's one of the biggest companies in Northern California. It has the lowest levels of chlorogenic acid in the industry. And so acid is produced by how they process it, how they roast it. They use a proprietary air roasting that minimizes the production of acid. And they were shocked at when they went to market, people started calling and saying, I don't get stomach aches when I drink your coffee. And they were so fascinated by that, they sent it up to UC Davis, University of California, Davis, to get it tested. And it was UC Davis that was able to prove that of all the coffees on the market, Bella Rosa coffee is really genuinely, truly extremely low acid. So you could try that. They have regular, they have half calf, they have decaf. But if you react to the Bella Rosa, then you bring it down and you go to the herbal coffees like Dandy Blend. We sell Dandy Blend too. That's what I drink. I cannot do regular coffee anymore. It messes my heart up too much. My heart is like on a hair trigger to any caffeine, and I can get AFib and I can get tachycardia. So I cannot touch coffee. I can drink Dandy Blend all day, every day. It tastes great. You can make lattes with it. You can make frappuccinos with it. It's fantastic. So I would encourage you to try Dandy Blend. Lots of people use it and they love it. And the cool thing about it is if you drink coffee in the morning so that you can have a bowel movement, I'm telling you right now, Dandy Blend has exactly that same effect. Exactly that same effect. So here, hold on a second. Amy says, terrible that insurance companies have so much control. Yeah, man, it's all about the money, honey. It just is. I mean, and that's really why this election was so incredibly important, was to make sure we didn't give them more power to raise prices and decrease services. Unfortunately, that didn't happen. So again, we have to see. We're going to have to wait and see what the new administration intends to do. Listen, with luck, it gets better. And I truly hope that it gets better. If it doesn't get better, then, and they start cutting our insurance, then, and raising prices, then you're going to have to make your vote count in 2 years. Hold on a second. Cassidy said she had quite a few resistant genes detected in your testing. Isn't that fascinating? Hold on a second. So will Peora help with the bladder builder? Bladder builder already has Peora in it. It has the active ingredient in it. So you don't have to buy two, but you could certainly do an extra Peora or two on top of the bladder builder if you wanted to. I mean, there's no known drug interactions. The last time I checked, as I've searched that many times on behalf of patients, and the research studies continue to say no known drug interactions, and the dosing is variable. And so doing one extra, I don't see that as an issue, but you won't know it until you try it. And if you have any doubts, you have to talk to your doctor, because it's not my job to give you medical advice. It's my job to educate you. And then you kick you in the butt and get you back to your doctor, ideally. Marlia says, I just bought pee, but I have elevated liver enzymes on occasion. This is something new that just started in April. It's always something, darn it. So I have to clear it with my doctor to make sure that it won't mess up my liver. Yeah, do you have CVID, hun? Not COVID, but CVID, which is an immunoglobulin issue that can sometimes affect the liver. Let me see if I can just find an answer for you. Let me just go to the National Library of Medicine and just see if anybody studied liver enzyme levels. I'm pretty sure they have, because there's so much research behind it. Let's see. Micronized PEA ameliorates methionine and choline deficient diet-induced non-alcoholic steatohepatitis by inhibiting inflammation and restoring autophagy. So, non-alcoholic steatohepatitis has become one of the serious causes of liver diseases, characterized by hepatitis or hepatic steatosis, hepatic cellular injury, inflammation, and fibrosis. PEA, here. Hold on. So this study was exploring the potential protective role of PEA on this liver thing. They found that PEA treatment significantly improved liver function, alleviated hepatic pathologic changes, and attenuated lipid accumulation and hepatic fibrosis in these mice. It was an animal study. PEA exerted a clear anti-inflammatory effect through ameliorating the expression of inflammatory mediators and suppressing the NLRP3 inflammasome pathway. Okay, so that's extremely academic. So that was the first study. It's a zebrafish study. PEA counteracts hepatic metabolic and flexibility modulating mitochondrial function and efficiency in diet-induced obese mice. Well, these are extremely academic studies, hon. In animal models, I think I would have to dive into it a lot more to really understand it a little bit more. But it's encouraging that they've been exploring that and they've found some success. Diane, hey, what was that message? You deleted it? What about a caffeine pill? No, no caffeine. Caffeine is neurostimulatory. It turns nerves on. It irritates nerves. Amy, no. No, big giant no, no, no to a caffeine pill. Dean says, my urine culture showed Kendall's pneumonia. What is that? Let me see if I can find it. Is it Kendall's or Klebsiella? This Klebsiella pneumonia, it's a bacteria that can cause UTI. It's considered a major public health threat and has been a common cause of hospital-acquired infections for many years. Yikes. Amy says, no caffeine, I'll live. Hey, man, I had the last caffeine I had, I ended up in the emergency room with my heart racing and I had PVC. I was having terrible PVC. This was like 6 years ago. And I have a history of PVC, long history of PVCs. My dad had them too. And those are preventricular contractions. They're really, really, really violent, hard contractions of your heart. It's like your heart's bouncing off your rib cage when it happens. Not fun. Anyway, I can still remember the ER doctor coming in, just looking me dead in the eye and say, "You may never have any coffee again. Never. You're too sensitive." And now it's just getting more sensitive as I'm getting older. So, like, I'm on a lot of meds right now. My dad refused all meds. He lived till 100. He kept saying, "Oh, and you guys, I gotta say this right now. Listen, for those of you old timers who have been here for a while, you remember my dad. He would come in during our meeting, Jack Osborne, and I provided his all of his care for the last 20 years. Same with my mom. And tomorrow is his birthday. He would be 102. I lost him at 100 and a half. So I lost him last May. So tomorrow is his 102nd birthday. And it doesn't make me cry to say that now. I'm just like, I just want to. The IC network would not be here if he hadn't cared for me when I was so ill. The only reason I exist today is because of my dad and my mom when I was 30 and I was so ill. They cared for me. They drove me to the hospital. They drove me to the ER. They drove me to San Francisco as I was writhing in the back seat, unable to sit. And I'm so grateful for my parents, because if I had not had them, I can honestly say I would not be here. And it was my honor to care for them as they were older, because they cared for me. And so a happy heavenly birthday to my dad. I swear, it's like I can feel him right now standing beside me or behind me, waving into the camera. "Hi, everybody." Because he did that so often. Oh, good memories. Diane says, "I'm wondering if there are a lot more adverse events listed in comparison to Xtronics because more inner stims are implanted." Um, so we just a couple weeks ago, we did a deep dive into the FDA database, and there are thousands of adverse events reported with InterStim. And up until maybe 6 months ago, there were hardly any for Axonics, but now there are more for Axonics. Um, Most of them are for the device moving and being removed. And I swear it was either last weekend or last meeting or the week before that. We actually went to the database and I read out the adverse events for both. The adverse events for InterStim are generally, I think, a little bit more moderate to severe. A lot more infections, a lot more MRSA infections, a lot more injury adverse events filed. Whereas with the Axonics, there was some injury, but there were also device removed because they didn't work and other things like that. It's just anytime you're considering InterStim and anytime you're considering a surgical neuromodulation, you cannot accept a sales rep or a doctor saying, "Oh, it'll be fine." You just can't do that. There are way, 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 way too many adverse events that have been filed, including fatality. The last time I counted up the fatalities there were at least 20. And the most recent fatality was like in December of last year. And it was of a patient who had InterStim. The doctor who implanted it had moved away. The patient developed a severe infection. The local doctors who were trying to treat him in the hospital did not know how to treat it, and the patient died. So, I say be well informed of the potential risks before having something implanted in your body that's foreign. Um,
Marlia says, was just told that I did not have hepatitis B or C. Thank God, just sludge was found in the liver, whatever that means. So that's from your gallbladder. That's basically kind of liquidized gallstones, I think. Liver test went back to normal a few months ago, and then it elevated slightly last week. So I have to retest in December. So that could be related to gallstones, hon. So I had my gallbladder removed last March, and I had this terrible chest pain. And when they did the blood test, my liver enzymes were off the charts because my gallbladder was completely blocked. So that's a sign potentially that something might be going on with your gallbladder. Amy says the bladder burns, so that could be a nerve. I'll have to go on a strict diet. Well, your job is to protect your bladder and to protect the nerves in your bladder. And so no caffeine pills, no strong caffeines. I mean, really, just don't do it. Dean says, how could you have gotten all these drug-resistant infections? Either you took a lot of antibiotics when you were younger and the bacteria learned how to defeat the antibiotics, or you've eaten really bad, poor meat from factory farms, because a lot of these drug resistancies are coming from factory farms. So when I buy meat, chicken, turkey, whatever, I do not buy big national brand names like Jimmy Dean. I don't want to buy meat from a factory farm. I look for local producers of organic eggs, local producers of chickens, etc. And so if I bet money that it's from food, I mean, you don't know where the beef that goes in a McDonald's hamburger or Burger King hamburger, you don't know where that came from. You have no idea where that came from. And that bothers me. I want to know where the meat that I'm eating comes from. It could come from a foreign country. It could come from a foreign country using a massive amount of antibiotics. So I'm very, very, very suspicious of fast food. Fast food, for a reason, is cheap. So how do you get cheap meat in a factory farm where you give them a lot of antibiotics? And man, if you want a burger, go buy a nice high quality ground beef and make a burger. Don't assume that the fast food companies are trying to give you good food. They're not. They're just trying to make a buck, in my opinion. Dean says, what was wrong with me when I was 30? Well, that's when bladder pain hit, when I was 32. But see, I had frequency urgency in 7th grade. I had vulvodynia in high school. I had IBS in my early 20s. I got migraines in my mid 20s. And, the related conditions to IC. And then I had very terrible bladder pain in my early 30s. It was triggered, ironically, from a swimming pool. What I didn't know is that I had all this nerve damage going on from all these other related conditions. So it was kind of the straw that broke the camel's back that put me into massive, massive pain. I mean, I had days where I couldn't sit, I couldn't stand, I couldn't lay down. All I could do was pace and cry. I had nights where I was writhing on my living room floor in agony, trying not to cry and wake up my family. And then I wouldn't flush the toilet because I was peeing every 10, 15 minutes all night long because I didn't want to wake him up. Man, you become a master of that. You pee and then you put your toilet paper in the trash can so it doesn't plug your toilet. That's what severe, severe bladder pain causes. And it's real suffering. I mean, you can suffer. The pain of IC is related equivalent to terminal cancer pain. This is not little pain. This is organ pain. This is big time pain. And I had a doctor say to me, you will always live with pain. This is your life. Get used to it. You will always be a burden on your family. I had a doctor say that to me at the emergency room. And that's a moment that changed my life, because that's a moment I came home and I went, oh, hell no. I will prove you wrong, you son of a bitch. And I came home and I started studying. And I proved him wrong. I have not lived with that level of pain for at least 15, 20 years because we found the underlying problem. The underlying problem was, for me, was very, very tight muscles and a jacked up nervous system. Now that I've gotten the muscles treated and I've calmed my nervous system down, virtually all of that pain went away. But I'm still very sensitive. And that's what happens with an injured nervous system. So I have to protect that nervous system. And I do. And I'm most of the time I'm good. Leanna says, have had many UTIs, each come back without any growth. Last one had no growth, but many organisms. What does that mean? Leanna, you have to understand that the bladder only knows one language: frequency, urgency, pressure, pain. So everything feels like an infection. A bullet wound feels like an infection. A stab wound feels like infection. So it's only natural for patients to assume that when you have the symptoms of frequency, urgency, pressure, pain, that it's an infection. When it's actually not for most of us. It's what an injury does. It gives you the same symptom. So the fact that you're having cultures and they're coming back with nothing, that's a good sign. But if you have any doubt, have a next generation DNA urine test and let's see what that finds. If that comes back negative, then it's not infection, it's injury. It could be from having a cup of coffee in the morning. It could be from drinking a Mountain Dew. It can be from chemotherapy. It can be from other things that can injure the bladder and or the muscles and or nerves. It can easily be very, very tight muscles causing all of this. Shelley says, I've tried almost all medications. I go to a pain and spine clinic. My urogynecologist refuses to do the microgen test. I have pain after urination and bowel movements. I take Urabel and Lyrica. Well, pain after urination, pain after bowel movements is not bacterial. It's usually pelvic floor muscle driven. And so, Shelley, so again, what do our guidelines say? If you're not responding to therapies, if you're getting worse rather than better, stop what you're doing, take a step back and revisit the diagnosis. Bladder therapies haven't worked for you. Maybe it's because it's not being driven by your bladder. Maybe it's being driven by your muscles and nerves. And so have you had a pelvic floor assessment? That's what I want to know, because you're having pain after urination, you're having pain after you have a bowel movement. Most of the time that tells us that we're dealing with tight muscles. So what's going on with your pelvic floor? Leanna says, thank you so much for answering my question. You're welcome, hon. That's why I'm here. Shelley says, I also had a pudendal nerve block. Oh, here, hold on. Shelley says, tried almost all meds. I go to a pain and spine clinic. My urogynecologist. Okay, here, wait, hold on. She said, I've also had a pudendal nerve block, both sides, ganglion nerve block, having issues from that now. Help. Okay, so the fact that they're doing nerve blocks means that they do believe that this is being driven by a nerve. Have you had a pelvic floor assessment? Are you doing physical therapy? Have you done that yet? Belle says, how do you calm your nervous system down? Well, Belle, isn't that the $6 million question? Oh, gosh. Okay. Number one, cut way back on hostile chemicals, especially for your skin down there. So that means no douches. You got to be careful with your soaps. Protect the skin. If I'm wearing a mini pad right now, it's an organic cotton mini pad. If I try to wear an always pad, it always triggers the nerves down there. Within 5 minutes, I'll usually have urethral pain. Same is true with laundry detergent, fabric softener. I use a 7th generation Free and Clear. I would never touch a national brand like Cheer or Tide. No fabric softeners, no dryer sheets, nothing like that, which is going to trigger the nerves in your skin. You can't use anything that leaves a chemical residue in your underwear, which can, so like, again, a fabric softener, something like that. Oh gosh, what else did I do? Lidocaine cream down there just to calm the nerves centrally. I'm using a lidocaine cream now along my breast cancer incisions, just to try to keep everything as calm as I can. I think the biggest challenge is just understanding and respecting the fact right now that our lives are just too stressed, that our daily lives are filled with things which amp our nervous system up. From social media, social networking, to reading the news, to spending time with people that are angry and upset. You know, I have to have I used a technique called the red bubble technique, or the pink balloon technique. So, our biggest challenge with the internet right now is that people jump on you. I mean, guys, I started the first support group 30 years ago on the internet. I've been around a long time. And you cannot let strangers affect your self-esteem. You cannot let a stranger write something on the internet to upset you. It should not upset you. This is somebody who is not important in your life. This is somebody who does not know. You cannot give your power away. Period. End of story. And there's that argument. The only person that wins in an argument with a crazy person is the crazy person. You see somebody being bonky online right now, and there's a ton of bonky people online right now talking about the election, no matter what side they're on. Walk away. You don't need to be involved in their stress. These are not important people to you. These are not important people to me. So with the pink balloon technique is a technique I learned in grad school, where basically you have a pink balloon or whatever color around you at all times. And the only messages it lets through are messages from people that are truly important to you. All the other shit you might read online bounces off. Listen, I spent a lot of years crying the first 5 years of the IC network because I could not make everybody happy. And believe me, I was criticized a lot by people who were angry, the people who were trying to sell things, the people who were I had one guy who was saying you can cure your IC by sleeping on a magnetic bed pad. And when I said not on my website, I was threatened. Who the hell do you think you are? This is free speech. It's like, prove it, bud. Prove it. You're not using my website to sell your stuff. You go out and build your own website, right? And it's kind of like an emotional hygiene decision. And I think the other challenge is we just really, really, really have to look at our daily life. And are we being supported and encouraged, or are we being challenged and minimized? And you have to be really protective of your emotional space. If you hang with people who complain all the time, that does you no good. I mean, I have a couple of patients who call me consistently, and I'm always happy to talk with them, always. But I always know exactly what's going to happen with this particular group of patients, which is going to be complain and complain and complain. Everybody else is the problem. They're not the problem. And it's like, no, self-responsibility here. Every day we have to do things that give us comfort and joy. And we have to walk away from things that stress us out and hurt us. And if that means we have to walk away from a friend because they're always bad-mouthing other people, you got to do it. You just have to do it. It's not your job to listen to somebody else's bitching. Your job is to protect yourself. And it's just becoming all the more, it's just been like my biggest challenge in the last 30 years doing the IC network, because I'm on the internet every day. And all I can tell you is that the less I involve myself in social media, the better I feel. Gay says, my family is my support system. Yeah. Yeah, absolutely. Having people who love you. And I think that that's like my biggest regret right now is that, my IC was so severe in my 20, I mean, my pain conditions were so severe in my 20s and in my 30s that I struggled to date. And the guys I did date, they were like, "You're too thick." I had one guy, Todd, he was a great guy. He's like, "Hey man, I watched my mother die. I don't want to watch you die." And I ended up alone. And I'm still stunned that I don't have a bunch of children because I thought I'd have 5 children. I don't have children now. And my life feels very empty, very empty. And, we all have our own journeys, and it's my job to try to fill that. And one of the ways I fill that is by helping other people. So, anyway, well, listen, guys, the sun is going down. As you can see, it is getting darker and darker. We have been on now for 3.5 hours. So let me go ahead and do a last call for questions. Last call for questions. If you find these meetings helpful, come on over to our website and join our mailing list. Buy something in our store like the Peora or our book, IC 101. It's not just a bladder disease, because that's why I can do these meetings. It's not like I'm a wealthy millionaire who can just do this and talk forever. I have bills to pay and health insurance to pay for. So, if you, please think of a way of supporting us if you'd like to do that. I'll never ask for money in front, but behind the scenes, think about it. Okay. So last call for questions, last call for questions. I gotta think about, what am I going to do for dinner tonight? I'm going to tell you what I'm going to do. I'm going to do organic unsalted tortilla chips, low salt pinto beans, an avocado, and maybe some rice. That's going to be my dinner. God, I do not need beans. I do not need, oh God, no, I do not need beans. Believe me, my body does not need any beans right now. But anyway, I think I'm going low salt Mexican tonight. We'll see. Okay. Well, all right, my friends, I think we're done. I'll see you next week. Knock on wood. Please, God, watch over me. Been a crazy year. I wish you the best. If you have any questions, please don't hesitate to give us a phone call. 800-928-7496. I'm going to call it here. I'm going to say goodbye to Facebook first. All right, bye. See you later, Facebook. Thank you, Gay. My magazine is, I think, where we do our best work. IC Optimist. Our members get it. All right. All right. Facebook is done. All right, YouTube. Thanks for hanging out. And hopefully we'll see you next week. Knock on wood. I hope it's a better week. It's been a rough week. All right.